Hey everybody, my name is Dr. Scott Giacomucci. I'm the author of Trauma-Informed Principles in Group Therapy, Psychodrama, and Organizations, Action Methods for Leadership. And in this video, I want to outline some of the content that I wrote about in Chapter 2 of the book, which focuses on psychodrama and group work as trauma-informed philosophies. So group work and psychodrama were created long before PTSD and trauma were really recognized. However, both of them as systems and approaches inherently mirror trauma-informed care, embody trauma-informed principles, even though they were created long before trauma-informed care was even a thing. So when we think about group work and compare it to individual work, there's some fundamental differences. Of course, group work takes place within a group, whereas one-to-one work takes place within a one-to-one setting. And because of that, there's more opportunities to implement some of the 6 trauma-informed principles. For example, the third trauma-informed principle, which is peer support, is far more amplified in group work than it is in individual work. Because in a group, there's a bunch of other group members that are there. And as facilitators, we can position group members in ways that they can support each other, that they can engage in peer support, they can engage in mutual aid. Whereas in one-to-one work, we just don't have this possibility because there's not other clients in the room with us. In group work, there's also more opportunities for cultivating safety. Safety is the first trauma-informed principle. As humans, we find safety in groups. We're kind of like herd animals or social mammals, really. And so we might feel safer with our peers than we would feel with a professional that has power over us. So group work, just the structure of it, creates more opportunities for cultivating safety. Similarly, the second trauma-informed principle, which has to do with trustworthiness and transparency, might be easier to cultivate in a group setting. Many trauma survivors might struggle to trust a professional, especially if they've been hurt by professionals or somebody that had power over them in the past. And instead, they might feel much more able to trust their peers who are part of the group. So we don't have this possibility in individual work because there aren't any other peers in the room. The fourth trauma-informed principle has to do with collaboration and mutuality. And of course, we can cultivate this in one-to-one work, but there's far more possibilities for collaboration when there's more people in the process. And so group work has more opportunities and more potentialities for collaboration and mutuality than individual work. The fifth trauma-informed principle has to do with empowerment, voice, and choice. And of course, again, we can cultivate this in one-to-one work, but there's more opportunities to do so in group work. Sometimes it can be really empowering to see peers tap into their own sense of personal empowerment, to reclaim their own voice in the aftermath of trauma, to demonstrate the capacity of decision-making and making choices, honoring their preferences and choices, having boundaries about choices they don't want to make. And so many times we learn through mirroring and through role modeling. And there's going to be far more opportunities for this in a group setting than in a one-to-one setting. And then the sixth trauma-informed principle has to do with addressing issues related to culture, gender, and history. And while we certainly can do this in a one-to-one setting, there's going to be far more opportunities in a group setting for these types of issues to emerge and just a more dynamic social context with individuals in the group with varying intersecting identities and varying experiences and perspectives related to their identity, related to culture, religion, gender, sexuality. And so these issues and a sense of solidarity around these issues might feel much stronger, more powerful, more corrective, more healing in a group setting than in an individual setting. Group work approaches, including psychodrama, really inherently embody trauma-informed principles and trauma-informed care, even if they were created long before trauma-informed care was even a thing. So while these principles and these philosophies are really embodied in group work and in psychodrama, it's really unclear how many group workers are intentionally and consciously integrating trauma-informed principles into their group work practice. So part of my intention for writing this book and making these videos is to really help group workers be more intentional and conscious about how they're implementing trauma-informed care into their work. My sense is that many group workers do this naturally and organically without even knowing it, and that it really helps to have the language and the framework of trauma-informed care and the 6 trauma-informed principles so that we can really intentionally and consciously further integrate these principles into our work. So group work is both trauma-informed and it's also a trauma-focused approach. So remember from previous videos, trauma-informed care describes the overall philosophy, the framework from which we provide services, whereas the term trauma-focused describes the actual nature of the services being provided. So when we say trauma-focused treatment, that means we're talking about treating PTSD, CPTSD, and trauma-related issues. So I wanted to read a quick little excerpt from the book that I think really captures the essence of some of these ideas. While trauma damages relationships and communication, group work promotes interpersonal skills and healthy relationships. Trauma is characterized by control and helplessness, while group work is based on collaboration and mutuality. Trauma often takes away one's sense of safety and belonging, whereas group work promotes a sense of safety and belonging. Trauma and PTSD fuel distorted beliefs about ourselves and others. However, group work offers reality testing and a reconfiguration of distorted beliefs. Relational trauma frequently fuels reenactments in relationships or insecure attachment styles. But a therapy group serves as a safe container for corrective and healing relational experiences while allowing us an opportunity to renegotiate attachment styles. Trauma fuels defenses and walls, where group work promotes vulnerability and authenticity. The group work approach is fundamentally reparative for trauma survivors. Now, there's multiple different approaches to group work, and in this chapter, I outline three different approaches. The mutual aid model, which comes from social work with groups, and as a social worker, perhaps I'm a bit biased to the social work with groups approach. Then I outlined the therapeutic factors from Yalom's approach to group psychotherapy, which is another very popular group work approach. And then later in the chapter, I talk about psychodrama as a group work approach. So the mutual aid model, which comes from social work with groups practice and theory, is really about promoting peer support in group works. So I thought it was particularly fitting to talk about this model in the context of trauma-informed group work. So mutual aid is essentially a synonym for the third trauma-informed principle of peer support. Mutual aid describes the phenomenon of two people coming together and mutually supporting each other, helping each other. And of course, the person that's doing the helping in the dyad also experiences positive benefits while they're helping somebody else. So mutual aid and peer support really provide a sense of healing for both parties involved. Mutual aid is a powerful model and framework because it really redistributes the power within the group. Instead of this old idea that the facilitator or the doctor or the group therapist is the person with all the therapeutic power in the group, the mutual aid model, similar to psychodrama, really emphasizes that the power is within the group, not within the group leader. And so in really emphasizing that the power is within the group and between the group members, not just with the group therapist or the doctor or the facilitator, this naturally helps to prevent re-traumatization in the group because it really focuses on positioning group members to provide healing for each other rather than expecting it all to come from the facilitator. So there's kind of a disruption of power dynamics and a redistribution of power to the group rather than between the group and the facilitator. And this, of course, is very empowering, which is one of the fifth trauma-informed principles, in that it empowers the group to become therapeutic agents for each other. In the mutual aid model of social work with groups, the primary purpose, the primary function of the group facilitator is to put into motion processes that cultivate mutual aid, that promote peer support in the group. And in the mutual aid model for group work, there's 10 different mutual aid dynamics. And I'm going to run through them real quick here. So the first one has to do with the sharing of information or data. And so this is simply the process by which group members and the facilitator are sharing with each other, are sharing information about themselves, about their experiences, about the topic. This might be a little bit of psychoeducation from the facilitator in the group, or this could be the sharing of data or information from other group members. But that there's a richness that we get to in mutual aid group work that we just wouldn't get to in one-to-one settings because there isn't as much information available to 2 people as there are to 8 or 10 or 15 people in the group. So the first dynamic is sharing of data. The second dynamic is what we call the all in the same boat phenomenon. And so this describes the sense of solidarity that emerges in group work when everybody's there for a shared purpose and or everybody is there having had a similar experience. That we all start to feel like we're in the same boat to some degree, that we're moving in the same direction, we're part of the same group, we're part of the same party, we're cut from the same cloth in an essence. That this phenomenon, this solidarity, this group as a whole experience emerges where we all feel like we're part of something bigger than ourselves, something bigger that we've co-created because we've come together with a shared experience or shared purpose, that we're all in the same boat. And this can be particularly powerful because it allows us a new perspective, but also when the group feels empowered, it also contributes to the individual empowerment of each person in the group. That as the group cohesion develops, it has a determining influence on each individual within that group. So this all in the same boat phenomenon is particularly important in group work. The third mutual aid dynamic is called the dialectical process. And so this essentially has to do with the safe expression of different perspectives, of differences, of experiences between group members, between the facilitator, which leads to the kind of a refinement of complexities about the experience, and at the same time, a sense of commonality within the process. That as different group members share their similar and different experiences related to the same topic, the same issue, we start to come to a deeper appreciation of the similarities, differences, and just the complexities within the group. The fourth mutual aid dynamic is about addressing taboo topics. So taboo topics always come up, or almost always come up in group work. Things like trauma, perhaps, is a taboo topic. Sex might be a taboo topic. I think taboo topics are really going to depend on the kind of cultural frame of reference and probably the age range in the group, and also the setting that the group takes place in. So one topic which might be very taboo in one group or one community just isn't going to be a taboo topic in another group or community. But regardless of what the taboo topics are, the topics that people don't want to talk about, the topics that are underneath the surface but that are emerging in the dynamics, the topics that get swept under the rug, the topics that are uncomfortable to bring up and uncomfortable to talk about, the topics that bring us a sense of shame, perhaps, or a sense of discomfort, a sense of anxiety when they're talked about. these things need to be addressed, and they tend to come up in groups. In one-to-one work, the facilitator has a lot more control over what's happening and what topics come up, whereas in group work, a lot more of the control of the process rests in the hands of the actual group. And so these taboo topics tend to emerge more frequently in group work. And some have suggested it's one of the reasons why many therapists, social workers, avoid leading groups, because we feel more control when we're in one-to-one settings. So the fifth mutual aid dynamic has to do with developing a universal perspective. And so this is somewhat similar to the second dynamic about the all in the same boat phenomenon. But this fifth dynamic is more about perspective and a universal perspective, that each individual comes to the group with their own individual perspectives. And through the sharing of all these different individual perspectives, we come to develop an appreciation for a larger, collective, universal, perhaps a more objective or maybe intersubjective perspective that takes into account varying different perspectives rather than just our own. And so this really helps with restructuring distorted beliefs and expanding one's sense of perspective about their individual experience. Sixth mutual aid dynamic is simply mutual support. And so this is what we've been talking about in terms of peer support, that we want to cultivate the connection and the mutual support, education, and healing between individual group members. We want to position individuals within the group in ways that they can face each other and support each other, contribute to the healing for each other. The seventh mutual aid dynamic has to do with mutual demand and mutual expectation. And so within group work, there's ways that we can use a reciprocity or role reciprocity to put a mutual demand on the group and on individuals within the group to show up and support each other, to help each other. When group members feel like there's an expectation on them, maybe other group members are putting an expectation on them to contribute to the group, or the facilitator is putting an expectation on them, it might help them show up in the way that we hope or expect them to. The way that we know that they could show up and support each other. And so mutual aid groups are different in terms of demand and expectation, in that all of the demand for healing, for support, for education is not on the facilitator. That we shift that role demand, that role responsibility, that role expectation onto each member of the group. And we try to empower them to show up, to share all of their strengths, all of their wisdom, all of their experience, all the information available to them with the rest of the group and the other group members. It creates a much more rich and dynamic group experience. The eighth mutual aid dynamic has to do with problem solving. So most people, when they come to a group, they come because they've got a problem, or they've got a series of problems that they're trying to make sense of, that they're trying to solve. These might be intrapsychic or internal problems. They could be interpersonal problems, or they might be social problems that are really impacting their life in different ways. And so, and you know what, I'll add to that, there could be spiritual problems or existential issues that they're grappling with. And so group members are often looking for answers, looking for solutions, or looking for somebody or a group that can help hold the pain, the uncertainty, the anxiety, the fear, the shame, the guilt, the anger, the frustration that comes with holding and experiencing the different problems they might be faced with. So within the group, there's often opportunities for group members to start to come to their own solutions to the problems they're facing, to work through and practice and experiment and learn new ways of addressing or responding to some of the problems within their life. The ninth mutual aid dynamic is about rehearsing new ways of being. So in psychodrama, we would think of this as role training, but the group experience becomes an opportunity for group members to practice different ways of being in relationship, different ways of being in community, and different ways of simply being. So in the group, somebody has a chance to rehearse and practice asking for help or setting boundaries or expressing their emotions or listening, connecting with others. And so this might happen really in implicit ways within the group process. This might be fueled by role modeling from other group members or the group facilitator. Or this could even be done through role playing and quite literally rehearsing new social skills. And the 10th mutual aid dynamic has to do with a strengths in numbers phenomenon. So naturally, trauma and some of the issues that group members might face within their life can be really isolating. And when we're isolated, we can feel like we might be the only one experiencing this issue. And that can be really disempowering. Whereas when we come together in a group or a community where other group members are all facing the same issue or similar issues, or have in the past faced this similar problem and found ways to cope with it or overcome it, we start to feel this strength in numbers phenomenon, where we start to feel a sense of empowerment. We realize that we're not alone. And this sense of safety, the sense of power, the sense of collaboration that emerges in this process really helps us to tap into that mutual aid and to feel a deeper sense of courage and strength to address some of the issues that we're grappling with. So these are the 10 mutual aid dynamics. The sharing of data, all in the same boat phenomenon, the dialectical process, addressing taboo topics, developing a universal perspective, mutual support, mutual demand and expectation, problem solving, the rehearsal of new ways of being, and the strengths in numbers phenomenon. So some have suggested that there's really a reciprocal relationship between mutual aid and trauma-informed principles. And this is a quote from a paper by Rosenwald and Baird. And this is published in 2020, I believe, in the Social Work with Groups journal. They say that mutual aid and trauma-informed practice become conjointly reinforcing, that mutual aid inspires a trauma-informed climate, and trauma-informed climate nurtures mutuality. I think this quote really sums it up pretty well, that trauma-informed care really promotes mutual aid and goes hand in hand with the mutual aid dynamics we just talked about. And when we cultivate a mutual aid climate, mutual aid dynamics, it really helps us maintain a trauma-informed setting. So mutual aid dynamics and trauma-informed dynamics go hand in hand. So at this point, I want to pause for a moment and I want to challenge you to reflect on how are you integrating each of these 10 mutual aid dynamics into your work? How do these 10 mutual aid dynamics show up in the groups you're facilitating? How do you help cultivate them in the groups you're facilitating? How do they show up in your community settings? How do they show up in your organization? Which of these mutual aid dynamics do you feel like you do a good job of cultivating in the group, community, or organization? And which of these mutual aid dynamics do you feel like you could more intentionally try to cultivate in your facilitation of groups, communities, or organizational settings? So next, I want to talk about another model for group therapy. And this comes from Irving Yalom, who is one of the most popular group therapists alive, perhaps. And he wrote the famous text, co-authored the famous textbook on group psychotherapy. And Yalom and his co-author Mullen Lezik outline 11 therapeutic factors that emerge within group work. And so these therapeutic factors are, according to Yalom and Lezik, these are the central organizing principles and the crucial aspects of the process of change in group therapy. So these therapeutic factors are particularly important. They're essential in group work. So the 11 therapeutic factors are the installation of hope. So this is pretty self-explanatory, but when we're facilitating groups, we need to we need to cultivate a sense of hope. We need to help group members feel like participating in the group is going to be worthwhile, that they might get what they signed up for, that their goals, their hopes might be fulfilled through the group process. We need to help them feel like there's a reason for continuing to live, perhaps, and that there's meaning and purpose in their experience and in the group. So we need to instill in them a sense of hope. Sometimes we do this through our own sense of confidence in our approach or in our group. Many times this happens in the mutual aid dynamics, in the interaction of group members, that when a group member sees another group member start to change or find new ways of addressing their issues, it instills a sense of hope for other group members, that maybe I could do that too. The second therapeutic factor is a sense of universality. And so this has to do with that larger picture, that larger perspective, universal perspective, a sense of the group as a whole phenomenon, that my experience is not isolated. I'm not the only one that's experienced something like this, or that's struggling with this issue, but that there's others and I'm not alone. And so this is particularly important when we're talking about trauma, because it can often feel like nobody could possibly understand, or nobody's gone through what I've gone through. So the second therapeutic factor, universality, helps to normalize the experience within the group, and it gives group members a broader collective perspective, helps them realize that they're not alone. The third therapeutic factor has to do with the imparting of information. And so this is just like it sounds, the sharing of experience, the sharing of knowledge, the sharing of coping skills, psychoeducation provided by the group facilitator. That there's a richness that happens in groups that doesn't happen in the same way in one-to-one settings, in that there's so much information that everybody brings to the group, including all the participants, and that there's a richness in the imparting and sharing of that information with others. The fourth therapeutic factor is articulated as a sense of altruism. So this is that goodwill towards others within the group, similar to what we were describing earlier as mutual aid or peer support. That when groups are cohesive and when groups are really tapped into their therapeutic potential, there's a natural sense of altruism within the group, that group members want to help their peers and want to help contribute to the effectiveness and the meaningfulness, the kind of fulfillment, the success of the group. There's a natural sense of altruism that emerges within the group, optimism, perhaps. The fifth of the therapeutic factors is called the corrective capitulation of the primary family group. So this basically just highlights how we all come from families, and in our early childhood, we develop different attachment styles based on our relationships to our family members. That our family is the very first group that we're a part of. Even if we experience trauma, abandonment, rejection, neglect from our primary family group, it still has a lasting impact on us as our first group experience. A family is a group. And so our experience early on in life with our family is our first long-term, ongoing, perhaps group experience. And oftentimes many of the sources or underlying fueling factors of our problems in adulthood can be traced back to problems we experienced in our early family. So the group experience in the here and now offers group members the opportunity to renegotiate the impact or the imprint of their early family group experiences. So we call this corrective emotional experiences. So, for example, if somebody experienced in their early family growing up, they were never listened to, or they didn't feel like their emotions were important or validated by others in the group. They were told to get over it, or don't cry, or don't talk about difficult things whether that was said explicitly or said implicitly through behavior. When they come to a therapy group, there's an opportunity for this to be renegotiated through a corrective experience where the group leader and the other group members really give this group member permission to talk about it, to be listened to while they're expressing emotions, to validate their feelings and their experiences, to let them know that it's okay to have feelings and that their opinions, their experiences, their sharing is important and valid. And of course, there's lots of different ways that we can tap into this fifth therapeutic factor, the correct recapitulation of the primary family group. It's going to be different for each person, and it'll probably emerge differently depending on the nature of the group and the primary focus of the group. The sixth therapeutic factor is the development of socializing techniques. So this has to do with really helping group members learn new social skills, essentially. That a group is a social setting, and that within the group, there's going to be social interactions. And so within the group process, we get to develop and refine all of our social skills. How well do we initiate conversation? How well do we approach someone that we don't know? How are we about asking questions and getting to know someone new? We get to develop skills around offering support, emotional validation to others, taking healthy social risks with others, learning how to set boundaries with others, making eye contact, and maybe even healthy physical contact with others. This is all part of development of socializing techniques. The seventh therapeutic factor is about imitative behavior, or kind of using role models within the group to help us practice or demonstrate behaviors that we might want to imitate, that we might want to replicate in our own role repertoire, in our own social skills repertoire. So someone might come to a group and really struggle with setting boundaries. So somebody might come to a group really struggling with setting boundaries, have an opportunity to see the group facilitator set boundaries throughout each group session. And they might get to see other group members set boundaries with a facilitator or set boundaries with other group members. And in doing so, they might get to see and observe and then imitate some of these boundary setting behaviors. And so this is what we mean when we talk about imitative behavior within the group. The seventh therapeutic factor. The eighth factor is called interpersonal learning. And so this is kind of similar to the sixth and seventh in that it's focused on the learning that emerges within a social context. That as humans, our brains are really wired for social learning, for interpersonal learning, and that we learn best in groups and in relationships. And so because the group is a interpersonal setting, the interpersonal learning that can take place within groups is really dynamic and maybe one of the main reasons that groups are so effective. Of course, we can cultivate a sense of interpersonal learning in one-to-one settings, but that only can take place between the therapist and the client, whereas in a group setting, there's just far more potentials and opportunities for interpersonal learning, that we get to learn from others in the group. We get to learn from the entire group experience. The ninth therapeutic factor is about group cohesion or group cohesiveness. So there's a ton of new research coming out about group cohesion and really showing it to be one of the most, if not the most important factor of successful therapy groups. Group cohesion describes the connectiveness, the kind of glue that holds the group together, that solidifies into a collective bond, an alliance between all the group members. So in one-on-one therapy, the therapeutic relationship, the therapeutic alliance, is often described as the most important aspect that contributes to the effectiveness of one-to-one therapy. And so in group work, group cohesiveness is that. It's the most important aspect. The group cohesion has a determining influence on each individual within the group, for positive or for negative. The 11th therapeutic factor is about catharsis. And so this has to do with the release of emotions, the sharing of feelings between group members and during the group process. Later on in this video, we'll talk about different types of catharsis from a psychodramatic and Moranian perspective. There's a ton of different types of catharsis. Usually when we're talking about catharsis, we're talking about an abreactive catharsis. And this is the expression of emotions, oftentimes accompanied by crying or tears or anger, an anger release of some sort, or perhaps laughing or other physical sensations. So catharsis is often part of the healing process. It's important that we don't overemphasize catharsis. I think there's distorted beliefs in the therapy world that catharsis by itself is healing when it's not. Often is part of the healing process, but needs to be followed up with some sort of cognitive learning or integration. So catharsis is the 10th therapeutic factor. And then the final therapeutic factor outlined by Yalom is about different existential components. And so Yalom, being an existential therapist, really emphasizes the various layers of existentialism within the healing process and within groups. And this might include discussions about life and death. This might include cultivating a sense of meaning, purpose in life, the time and dreams and goals, that there's all different types of existential factors that show up in our work, perhaps in every therapy group and every therapy session, and especially when we're working with trauma. Trauma can often lead us to a sense of existential crisis, really turns our life and our worldview upside down. So when we're doing group work, the 11th therapeutic factor has to do with addressing and even cultivating, making sense of all these different existential factors. So these are the 11 therapeutic factors: the installation of hope, a sense of universality, imparting of information, a sense of altruism, the corrective recapitulation of the primary family group, the development of socializing techniques, imitation behavior, interpersonal learning, group cohesiveness, catharsis, and existential factors. So in some of the other publications about these therapeutic factors, many people have highlighted how these therapeutic factors are specifically important and helpful for trauma survivors. These 11 therapeutic factors help to combat the sense of shame and isolation that often results after traumatic experiences. These therapeutic factors really help us challenge the negative beliefs, distorted beliefs about ourselves, about others, about relationships, and about the world that often result after trauma. These therapeutic factors promote a sense of support and trust between group members, whereas trauma often disrupts one's ability to trust or to be in supportive relationships. The therapeutic factors can, by themselves, really help an individual and a group manage different PTSD symptoms, a sense of avoidance, symptoms related to hyperarousal, symptoms related to intrusions or re-experiencing trauma, and symptoms related to negative beliefs and negative feelings. The development of these 11 therapeutic factors within a group setting really helps to, just in an organic way, validate the traumatic experiences that somebody may have gone through. They help to develop a new trauma recovery narrative for the group as a whole, and also for each individual within the group in a really safe way. These therapeutic factors help to facilitate the healthy expression of emotion and help to promote a new sense of identity in trauma recovery or in post-traumatic growth, a new and reintegration of the traumatic experience into our sense of self. These therapeutic factors help mobilize all the various strengths and resources within the group, within the individual, and in doing so, help replenish the sense of depleted inner resources or inner strengths that one might feel after a traumatic experience. And so these 11 therapeutic factors are really powerful, meaningful for trauma survivors, even though the therapeutic factors were not developed specifically focused on trauma-informed or trauma-focused group work. They were developed more in a broader group therapy context. And even though these 11 therapeutic factors were created for group therapy, they're also really important for organizational work, community work, and work within the larger framework of society. That these 11 therapeutic factors can be cultivated within an agency or an organization and help promote that organization towards the successful fulfillment of whatever their organization mission is, the goals within the organization. And that our work within organizations can also create healing for individuals within organizations. An organization is essentially just a group. The same idea goes for communities and societies, in that communities and societies are essentially just larger groups than a therapy group or groups that we might engage with in group work. So if you're part of an organization, and most of us are, I really encourage you to consider how these therapeutic factors show up within your organization. When you think about the various communities and the society that we're all a part of, I encourage you to consider how you might contribute to cultivating these 11 therapeutic factors within your communities and within society as a whole. And when you reflect on these 11 therapeutic factors in terms of group work and group therapy, it could be helpful to consider which of these therapeutic factors do I do a really good job of cultivating naturally in my group work? Which of these therapeutic factors might be important for me to more intentionally focus on in my group? Are there any therapeutic factors that seem to have been missing in the development of the group that I'm leading? In my own experience of participating in groups, which of these therapeutic factors were most important to me? Or which of these therapeutic factors might be most important to the clients, the populations that I'm working with? So I really encourage you to take a couple minutes and reflect on how these 11 therapeutic factors show up within your group work. So in the evolution of the research about group work, the research is really just pouring out, showing the effectiveness of group therapy as an effective treatment for a variety of different social issues and mental health issues. But one specific part of the research I want to highlight next is the developing body of information about how neurobiology, especially interpersonal neurobiology, might contribute to our better understanding of the dynamics within groups and the effectiveness of group therapy. So I'm not going to go into a ton of detail in the video about this because it's a really complicated subject. I encourage you to check out the section in this chapter on the book to learn more. Or there's also a chapter in my previous book, Social Work, Sociometry, and Psychodrama, that focuses on neurobiology and group work. Or there's a book called Integrating Interpersonal Neurobiology with Group Psychotherapy, where the entire book is devoted to this topic. So I encourage you to consider checking out some of those other resources. So in that last book I just referenced, the authors Gant and Badenoch have a quote that I thought was important to read to you about neurobiology and group work. They write that understanding the interpersonal nature of brain development and its role in illness, healing, and recovery also helps discriminate how group therapy is different from individual therapy, and in many instances may be a more powerful and logical choice from a brain-based perspective. So what they're saying here is they're highlighting how our brains develop in relationship to other brains, that our brains are really social in nature, that nobody's brain develops in complete isolation. That the circuitry within our brains, the actual structures within our brains, and all of the just the different aspects, different functions of our brain develop through social learning, within the context of relationships, within community, through mirroring, through attachment, and through relationships. And that the nature of our early relationships and attachments, especially with our primary caregivers, has a direct influence on our brain development. When we have secured attachment and healthy relationships with our caregivers and with our community, our brain tends to develop in optimal ways. When we experience neglect, abandonment, trauma, or abuse, ruptures in our attachments with our primary caregivers and our community, it impacts our brain development in ways that are not so helpful throughout our life. And so our brain development, which is based on our relationships in many ways, has a significant role in the development of mental illness, even medical and physical illnesses. It has a significant role in our healing and in our recovery process. And so individual therapy, of course, there's a social and interpersonal nature, an aspect of individual therapy, but that becomes much more pronounced in group work because there's a whole matrix of relationships within the group that perhaps more adequately simulates our experience in a family group and in a community group, which would be more similar to how the social settings looked throughout our early brain development. And so this is one of the main reasons why they're suggesting that from a brain-based perspective, group therapy might be a more powerful and logical choice for healing, for treatment, than individual therapy. And so in this book, they outline 3 primary group therapy components informed by interpersonal neurobiology that might be 3 of the main things to focus on related to neurobiology and group work. The first one we've already been talking about, and this has to do with brain development and memory. And so putting this in the context of trauma, when we experience trauma, especially trauma earlier on in our life, it can really impact not just our mind, but also our brain. And sometimes these traumas impact us at levels below thinking, below cognition, and it can impact our hippocampus's ability to store memory. Many times, traumatic memories get stored more so in the body, in implicit and unconscious ways, than just in the mind and the hippocampus in more explicit and visual memories. And so this is particularly true for relational trauma, complex trauma, and trauma earlier on in our life. And so because trauma gets stored and kind of imprinted on us in our nervous system, in our body, in implicit and unconscious ways, one of the ways of tapping into where the trauma is stored within the body, within the brain, is through experiential, relational, and symbolic ways, rather than just talking. And so the group experience really lends itself to this here and now experience within our body, within the group. That there's ways that we can renegotiate implicit memories within a group setting that we wouldn't be able to do within a one-on-one setting. That there's a different embodied feeling of being in a group than being in a one-to-one setting. And for trauma that we may have experienced within groups, within families, within community, within society, that feeling of being in a group might be essential or important in terms of healing from the ways we've been harmed by other groups. The second area they outline is about the group becoming a holding environment for each individual within the group. That the group essentially becomes a container that can hold all the emotions, the sensations, the feelings, the experiences, the stories experienced by each of the group members. This holding environment is kind of similar to the holding environment that we could create within a one-to-one setting or within a infant and caregiver relationship. That there's this experience of feeling held, of feeling attuned to, of feeling validated, of feeling seen and heard, of feeling felt, that we can cultivate in relationships, and that it happens in a very unique way within a group, that we can create a unique group holding environment for each person. The third primary area that they outline is about neural integration, and they talk about it within different domains, including integration on the level of consciousness, integration on an interpersonal and relational level, integration on a vertical level, and what they mean by that is the different hierarchical aspects of the nervous system and the brain that the group therapy experience helps us to integrate physical sensations within kind of older, lower aspects of the brainstem, within the kind of core central aspects of the brain, older aspects of the brain, with the limbic system, which is a newer, well, it's still old, but a newer kind of middle aspect of the brain. The limbic system has to do with relationships, with feelings, with emotion, with a sense of threat, with anger, with fight and flight responses. The limbic system is something we share with other mammals. And so integrating these two aspects of the brain with the cortex and the prefrontal cortex, having to do with the newer evolutionary aspects of our brain that we don't exactly share in common with other animals. This newer part of the brain that developed, the last part of the brain to develop in an individual's lifespan, but also in the evolutionary span of us as a species, it was the last part of the brain to emerge. And this newer part of the brain has to do with decision making, with rational thought, with a sense of self, with cognition, with future planning. And so when they're talking about vertical integration, they're talking about integrating all these different aspects of our neurobiology. And the fourth aspect of neural integration that they mention is bilateral integration. So this has to do with left to right side of the brain, left and right hemispheres of the brain. So it's important to mention that when we talk about left and right hemispheres of the brain, we're making some pretty big generalizations that are true for many and most people, but not for everybody. Generally speaking, the right hemisphere of the brain has to do with functions related to emotion, sensations, symbolic representation, visual, the senses, seeing, hearing, smelling, feeling. And this is the part of the brain that's very active in brain scans when somebody's remembering a traumatic experience. Whereas the left hemisphere of the brain has to do more so with rational thought, decision-making, cognition, perspective, meaning-making, thoughts, beliefs. And so you can see that these are a bit different in their specialization in terms of different hemispheres. And they actually find that for trauma survivors, folks experiencing PTSD specifically, that the connection and integration between these two parts of the brain are not as connected, not as integrated as somebody that's not experiencing trauma or PTSD. That there's a organ in the brain called the corpus callosum that connects these two hemispheres, and that it gets less blood flow, less activity when we're experiencing PTSD. And so part of the healing process, recovery process, has to involve promoting more bilateral integration to help connect and balance out feeling, and thinking states. So these are the three primary group therapy components outlined in this book, Integrating Interpersonal Neurobiology with Group Psychotherapy. Brain development and memory, group as a holding environment for emotions and sensations experienced by the group members, and the neural integration within the different domains of consciousness, interpersonal, vertical, and bilateral neurobiology. So when we think about the group as a whole experience in group therapy, it seems to initiate a right brain to right brain resonance between participants. That there's a way that the feeling of being in a group, the feeling of the group as a whole experience, the feeling of mutual aid and peer support, the feeling of being connected to others in the group provides this implicit, often unconscious, right brain to right brain connection and resonance between participants, which can be particularly healing and powerful. The group context is unique in that there's a multitude of peer relationships within the group experience that are likely to activate, maybe even to trigger, but can contain and help us rework some of these implicit traumatic memories within the nervous system and that seem to be stored more so in the right hemisphere of the brain. So this is just a simple, or not so simple, overview of neurobiology and group work. If you wanted to read more, I encourage you to check out some of the resources that I mentioned earlier. And I want to challenge you to take a moment to reflect on how can you use some of the neurobiology information that I've provided or that you've learned elsewhere to guide your practice of group work. So the next section in Chapter 2 talks about trauma-informed teletherapy guidelines. So, of course, teletherapy has been around for many years. However, the COVID-19 pandemic really fueled just an explosion in the use of teletherapy because it wasn't safe for many people to meet in person. So it was important that new guidelines for safe and effective and trauma-informed teletherapy were developed. So teletherapy, in some ways, really embodies trauma-informed care philosophy and principles. For one, telehealth can be much more accessible for many people who wouldn't be able to access therapy, group work in person, either because of the cost involved, because of mobility issues, because of the lack of services in their geographical area. Telehealth really is a game changer for many people, especially in rural areas or folks who struggle to afford or find affordable and accessible group therapy options. So telehealth is really important in that way. Oftentimes telehealth is cheaper than in-person therapy because the provider doesn't have the additional cost of paying for a building, paying for rent, or leasing out a space, and all the costs that go into that. Telehealth can be really empowering. And for many trauma survivors especially, telehealth might feel more comfortable and even safer than going to a strange place or a sterile medical environment, a new building, a new city or town that they've never been to meet in the office of a professional to engage in therapy. Whereas with telehealth, they can use a laptop or a phone or a computer and sign on to the session from the comfort, the safety of their own home, their own private space. So, of course, for many people, this is going to feel safer and more comfortable, which is especially important for trauma survivors. Although for some people, they're not going to have a safe place to do telehealth from. Maybe their home isn't and never was a safe place. Maybe they don't have the privacy or the luxury of a private space within their home. And so we need to take this into consideration as well. Some of the research has shown that group teletherapy participants feel a greater sense of safety, transparency, even honesty and comfort in online sessions than they do in in-person sessions. So Teletherapy for groups is an important option to consider when you're offering groups. And it really expands the ability of group members to participate in your groups because your kind of span of folks that might be able to be in the group is no longer limited by physical or geographical proximity, which creates more choice for group members. I think it really allows us to create more specialized groups because we have a larger sample of people who might be able to attend the group or participate in the group. It's no longer limited just to people that could travel, 30 to 60 minutes, to be in person for that group setting. But now it can include people within the entire state or throughout the country, even in some cases, although many of us are limited by our state licensing in who we're allowed to do telehealth with. So either way, telehealth creates far more options for participants in choosing groups, that they're no longer limited simply by the groups that are offered within geographical proximity of where they live or work. Telehealth groups are more time efficient in that it doesn't involve travel time. So many people either simply can't afford the time involved with traveling to and from a therapy group, or some people use it as an excuse not to carve out time in their schedule to attend a group. Either way, telehealth sessions are much more time efficient because they don't involve travel time. So for a 1 hour or 90-minute group session, if it's in person, many times for participants, that requires a 2 to 3 hour block of time in their schedule because they have to consider all the time driving to and from the group, not just the time that the group meets. So telehealth is much more efficient in that way, much more accessible in terms of time involved. Telehealth allows for individuals to come together for a group who probably wouldn't have been able to physically gather together easily before. And it allows for more specialized groups for specific populations due to the larger geographical region that we can pull attendance from. So I think this can be really important for that 6 trauma-informed principle related to culture, gender, and identity, in that we can create groups that are more specialized around different communities and different issues, rather than just broader therapy groups. Of course, there's also risks and limitations to telehealth, in addition to many of its strengths. Telehealth practice laws can be really limiting. If you're a licensed mental health provider, you're usually limited to only providing telehealth to individuals who are physically in the state you're licensed in at the time of the telehealth session. So while it might be easy enough to have people sign on to your group from around the country and around the world, oftentimes this would be considered practicing outside the scope of our licensing, and our professional liability insurance might not cover any issues that emerge if we're practicing with folks outside of the state we're licensed in. So it's really important that you stay up to date on the ever-changing telehealth licensing practice laws. There's also interstate licensing compacts that are being created. Some professions have done a better job than others in getting those off the ground. However, each state has to individually pass legislation to opt into that interstate licensing compact. So from what I understand, the psychologists have done a pretty good job and have gotten a couple dozen states to sign on to that compact. The counseling compact is gaining lots of traction. The social work licensing compact is still getting off the ground here in 2023. It'd be important that you're aware of your own profession and licensing compact options. Another limitation to telehealth practice is that practicing through telehealth requires different competencies for the professional, and especially related to technology. So we need to make sure that we are competent and able to skillfully use any telehealth technology that we're going to use. Sometimes it can be really helpful to have a co-leader when you're doing telehealth groups. You can have someone who can help manage some of the technology while the other co-facilitator is managing the group. In telehealth groups, there's additional risks to privacy and to confidentiality. So you'd really want to be aware of these additional risks. Some things you can do to mitigate some of those risks would be to use screen protectors or encourage group members to use screen protectors for privacy on their mobile devices or their laptops or computers if they're not able to sign on to the group from a private space. And of course, to use headphones when a private space is not available, so that people who are in their physical space aren't going to hear the things that other people in the group are saying. In Zoom groups, there's the risk of Zoom bombing, which is when uninvited people get a hold of the Zoom link and jump onto the Zoom meeting and start taking over the group, sharing inappropriate images or saying inappropriate things during the group. I think Zoom has done a pretty good job of creating features that allow us to prevent Zoom bombing, such as the waiting room feature or requiring passwords for Zoom links. So you want to be aware that you want to make sure you're aware of these features so you can prevent Zoom bombing. Now, there was a couple authors that put together and created 5 different ethical arguments about the risks of doing therapy online. And so their arguments were 5 different areas. One was about the confidentiality, privacy, and security risks of online therapy. Second was about the lack of therapist training in telehealth. Many therapists, perhaps most therapists, have zero training on how to provide therapy online, especially therapists that did their training and supervision prior to the COVID pandemic. Prior to 2020, there wasn't a whole lot of information, teaching, and education in graduate schools about online therapy. It was almost exclusively focused on providing therapy in person. The third area had to do with communication problems related to the technology. So, this could be things like unstable internet connections, having trouble with muting or unmuting, or turning on or turning off cameras during the sessions, difficult to hear or understand due to microphone or speaker problems. So there's different communication problems that emerge when we're using technology that just aren't present in in-person sessions. The fourth area they outlined was a lack of research on online therapy. Most of the therapy research was focused on services that were provided in person, not online. And the fifth limitation has to do with some of the complexities in managing emergencies during teletherapy sessions. So if there's an emergency, a medical emergency, a mental health emergency, a safety emergency, and the client is in person, it's a lot easier to address that, to manage that, to provide the individual or individuals with help, to get them to help, to get help to them. Whereas when everybody's online in a different physical space, there's a lot more complexities in managing emergencies. If we're on a Zoom meeting and somebody all of a sudden has a medical emergency, we need to know exactly where that person is so we can get help to them. If somebody's on a Zoom session, telehealth session, and starts to have a mental health crisis, they might turn their camera off or log off of the Zoom session without telling anybody, and we might not be able to get them help right away. Whereas if they were in person for the group session, we would be able to see what was going on, to ask questions, to make sure that everyone was okay before the group ended. So there's a lot more limitations and complexities in managing emergencies for telehealth than there is for in-person sessions. So I want to run through the 6 trauma-informed principles and different ways of cultivating these trauma-informed principles in telehealth. So the first trauma-informed principle is about safety, and some simple strategies for implementing safety on telehealth in group work would include things like obtaining the patient's location at the start of the session, really having a thorough informed consent process to outline some of the risks of telehealth, the limitations of confidentiality in group work and on telehealth, to get a commitment to confidentiality from each of the group members at the beginning of the group process and maybe even at the end of the group process, to talk about and confirm privacy and security of each patient, each client's physical and virtual space, to discuss the importance of keeping the video feed on and or communicate with the group leader about why somebody's turning their camera off so we can make sure everybody's safe and can help them manage feelings related to lack of safety or discomfort or feelings of overwhelm during the process if they were to turn their camera off. And to provide local and virtual resources for support, additional treatment, referrals, and emergency care based on the physical proximity, the geographical location for each individual based on where they're signing on to the group from. The second trauma-informed principle is trustworthiness and transparency. And so different ways to cultivate this in telehealth groups would involve utilizing reliable and secure telehealth platforms to promote transparency related to any noise in the background in the environment that somebody might be attending the session from. If somebody's in a public space and they're on a therapy group session and other people can hear discussions going on in the background, it'd be important to be transparent about what that noise is. To suggest that each person sit far enough from their camera so that others can see more of their body language. If everybody is sitting this close to the camera, you're not going to be able to see what they're doing with their hands, what's going on with their legs, with their body, their posture. Whereas if everybody steps away from the camera a bit, you can see much more of their body posture. You can see their hands, you can see their torso. You could see if they're leaned over, maybe in a more depressed stance, or if they're sitting up more comfortably, or if they look confident or comfortable, or if they look upset or angry, or if they seem afraid or sad. You'll just have much more physical cues to be able to have more transparency about what's going on for somebody. And then you'd also want to provide clarity on the telehealth and the group processes, which are going to look different for telehealth groups versus in-person groups. In terms of peer support, in telehealth sessions, you'd want to promote mutual aid and group cohesion, just like you would in individual sessions. But on telehealth, you'll have to do this in different ways. You might use things like group discussions, breakout rooms on the telehealth platform, the chat feature, or other processes adapted for the virtual group space. You could encourage participants to unmute their mics and contribute to the group throughout the process, and or use nonverbal indicators of support, such as emojis or images or physical non-posture indicators of support, or even the chat box. In terms of the fourth trauma-informed principle, collaboration and mutuality, ways to cultivate this on telehealth groups would include clearly identifying group goals and purposes that promote collaboration between the group members, and helping to develop a sense of solidarity and cooperation in the online group space by highlighting shared experiences. And again, you could do this through engaging the group members on telehealth. Sometimes it's harder to engage group members on telehealth than it is in person. There's probably more opportunities for distraction when somebody's signing on online than they are in person. The fifth trauma-informed principle is about empowerment, voice, and choice. And so ways to cultivate this in online groups would include discussing group norms related to keeping your microphones muted or unmuted, tracking all participants throughout the online group process, and empowering, ensuring that everybody has a chance to participate based on their comfort level. You want to make sure that you give everyone a chance to speak up and that you give everyone choices throughout the process. So you might want to initiate on ongoing check-ins and affirmations of choice throughout the group. And then you would be helpful for group members to consider offering alternative options for sharing instead of verbal sharing or talking. Again, things you could do to allow group members to engage in different ways online would be using emojis or the chat box or nonverbal ways of sharing. The sixth trauma-informed principle has to do with culture, history, and gender issues, and ways to address that online would be to intentionally create group spaces that are inclusive and affirming of diverse identities, diverse communities, to consider the impact of social determinants of health, such as housing security, internet stability, the affordability of computer equipment, access to private space for telehealth sessions, access to childcare, the impact of poverty, language translation, nutrition, racism. All these different social determinants of health have a determining impact on one's access to both in-person and online services in different ways. You'd want to also be aware of the patient's comfort level in revealing details of their personal space during the session. So you might educate or encourage clients to use a background that a feature, if you're using Zoom, for example, that blurs out the background or gives them an option to have a digital background in case they're anxious about other people seeing who or what might be in their background, maybe the cleanliness of their space or the simple lack of space that they have, or the other visuals related to their space, which might give indicators about wealth and income or poverty. Another simple thing you can do to address issues related to gender is encourage the use or display of gender pronouns next to participants' names. So this has become a pretty common practice in online settings. You could specifically design groups that are accountable or that take into account preferences and limitations related to different communities, and provide simple instructions for participants, especially those less familiar with computers, technology, or telehealth video platforms. So these are all different ways that you can practically, in very practical ways, implement strategies to operationalize the 6 trauma-informed principles in online telehealth groups. At this point, I want to pause for a moment, and I want to challenge you to reflect on how comfortable are you facilitating online groups versus in-person groups? And where are your varying levels of competencies and competence, your scope of competence perhaps, as a facilitator for online groups versus in-person groups? And perhaps you could include hybrid groups into that. Do you feel more comfortable and skillful facilitating in-person groups? Do you feel more comfortable or skillful facilitating online groups? And where's your level of comfort and skill in facilitating hybrid groups where some of the participants are in person together and other participants are online together? It's also important that you take a moment and reflect on if you've educated yourself on the ethical, legal, and clinical best practices for facilitating online groups, which are going to be different than the ethical, legal, and clinical best practices for facilitating in-person groups. So the next subsection in Chapter 2 talks about group developmental phases. And so this can get a little complicated because it seems like multiple different group experts have developed different language for talking about the different phases or stages that groups go through in their developmental process. So I want to give a quick overview of these different group development stages and the different language used by different authors in the literature. And it seems like, from what I can tell, kind of taking a bigger picture look at the different ways of conceptualizing group development, is that the different phases get conceptualized based on the professional background and orientation of the author or the practitioner. So Tuckman, going all the way back to 1965 in the psychology profession, outlined 5 stages of group development: forming, storming, norming, performing, and adjourning. And conveniently, they all they rhyme with each other, which makes it a little more fun and easy to remember, talking about the phases that a group goes through in its development. In that first, the group comes together, and it's not a group yet. It's just a bunch of individuals that are trying to form a group and form a sense of group cohesion. Once that groupness quality starts to establish, there's a storming phase. This is where conflict emerges. Differences have to be discussed. There's challenges to the authority of the group, the storming aspect. Then we get into norming. We're solidifying the norms of participation within the group. We're getting into more of the purpose that the group has come together for. Into the performing stage, where we're really doing the work that the group has agreed on, the goals, the purpose of the group, working through difficulties, addressing issues, trying to find solutions. We're healing. And then we get into the adjourning aspect of the group, which is where we're grieving the closure, the ending of the group. We're trying to celebrate the work that was done. Similar to these 5 group development phases, Corey, and Corey, in their group counseling textbook, outline 5 group development phases that follow the same trajectory. We have the forming stage, the initial stage, the transition stage, the working stage, and the final stage. In social work with groups, we simplify it into 4 stages: the initial stage, the beginning stage, the middle stage, and the ending stage. Mackenzie, who is a psychiatrist and group therapist, outlined 4 different phases to describe the same group development process. Mackenzie describes it as the engagement phase, the differentiation stage, the interpersonal work stage, and the termination stage. And then as a psychodramatist, I wanted to add in here Moreno's stages of group development, which focus on warming up stage, action, and sharing, or group psychotherapy stage. So the first 4 models I outlined were developed to describe the longer-term trajectory of a group's development over multiple sessions, multiple weeks, multiple months, maybe multiple years, while Moreno's group development stages were conceptualized based on a single session. That the beginning part of that session is a warming up process, the middle part of that session is the action phase, and the ending is the sharing. And so this would follow the 3 triadic components of Moreno's system. That the warming up phase of the group is focused on sociometry. The action phase of the group is psychodrama, if we're doing a psychodrama group. And the sharing phase of the group, the cooling down, is focused on group psychotherapy. It more so resembles traditional verbal group psychotherapy, where each person is sharing about their experience. But we can also conceptualize the longer-term group development through Moreno's 3 phases. That earlier on in the beginning phase, it's a warming up process for the group. The middle phase is an action phase, where we're getting into action about the purposes of the group. And the ending phase of the group has to do with cooling down. So these phases are kind of mirrored throughout the different models. And the way I like to think about it is that we're just using different language to describe these different, or to label these different phases, but we're talking about the same thing, regardless of what language we're using and what perspective we're coming from. And that Tuckman, the Corey's, the social work approach from Shulman, and Mackenzie's group development phases can also be used to conceptualize a single session even though they were created to conceptualize the longer-term group development. So these phases apply to all groups: therapy groups, task groups, organizational groups, supervision groups, classrooms, community groups. All groups go through these phases to some degree. All groups go through these phases in different ways, of course, and some groups might stay at one phase longer than other groups, or get stuck in one phase, or might not make it all the way to one phase if it's a more time-limited group, or there might be more difficulty or ease in different phases. But all groups over time will naturally go through these different phases. And there's different tasks associated with each phase and different difficulties associated with each phase. So usually in the beginning phases of the group, we're focused on developing connection, cohesion, a sense of mutual aid and peer support. We're trying to establish safety and group rules and norms. We're trying to get group members to know each other, to commit to the group, and to establish a sense of commonality and hope. The middle phase of the group development is where we start to get into the work that we came here to do as a group. We start to take and make strides towards completing goals that the group set out to complete. We work through difficulties and conflict. This is usually where confrontation, boundaries, difficult emotions start to emerge and need to be worked through. This is middle phase of the group is usually where most of the catharsis is experienced in the group process. And this can be the most intense part of the group for most of the group members. And then the ending phase of the group has to do with integration. How do we take the experience we've had together as a group and integrate it into our lives going forward, to integrate it into ourself, to take the emotional experience and to use it to develop new perspectives, new ideas, new beliefs, new cognitive restructuring within ourselves and based on our experience as we move towards closure and ending for the group. So, like I had mentioned, these group phases emerge for all groups, but emerge in different ways for different groups. And they seem to show up especially different for groups that have like a clear beginning and end and a cohort style, such as a 15-week therapy group or educational group. But there's a beginning and an end, and usually all the group members start at the same time and end at the same time. In a group structure like that, the group is going to go through a much more consistent and clear group developmental process. Whereas there's other groups where there's a revolving door of people joining and leaving the group. This will be especially true for just an ongoing support group that meets every week indefinitely, or an inpatient group where people are there for shorter term and discharging and admitting to the group on a more frequent basis. In groups with this type of revolving door, the process of group development and the phases that the group goes through are going to look different. For example, instead of the entire group going through this trajectory of beginning, middle, and ending phase, there might be different individuals in the group who feel like they're in different phases of group development in their relationship to the group, in their own process. So, for example, in my inpatient work, it's pretty normal that folks are only in my group for 2 or 3 weeks. And the group meets twice a week. So the first couple sessions, the first week, someone might be in my group, they might feel like they're still in the beginning phases of their development of their relationship to the group. Whereas the second week they're in the group, they might shift into that middle phase, and they might be working on the middle phase tasks related to the group for themselves. Whereas their second week of the group, new members might join the group, and those new members are now working on the beginning group phase tasks for themselves, trying to learn the norms of the group and feel a sense of safety, connection to the group. And then individuals that move on to the third or fourth or final weeks in the group, they might shift into some of the ending phase tasks for themselves around termination, ending, and integration, gratitude, meaning making. So in these types of revolving door groups, each individual might be in a different phase of group development. So I want to encourage you to reflect on these different phases of group development and to consider how they guide your group facilitation. Which one of these frameworks and which of these, the languages attached to the framework, feels most congruent to your way of thinking as a professional? Which one are you going to use to talk about and think about your group phases? How can this simple theory of group development phases guide your group facilitation? When you think about which phase your group is in and which phase is next and the different tasks associated with that phase, it'll modify how you approach the group and which interventions you use in the group, which topics you bring up in the group or try to contain in the group. When you think about the different group developmental phases, which ones do you feel most competent and comfortable leading groups during? Whereas which of these group developmental phases do you feel least comfortable leading a group when it's engaged in? And I would encourage you to also reflect on how can these different phases of the group session really help you in structuring and pacing your group sessions. So similar to the different phases of group development, we also have 3 different phases of trauma recovery. And just like there's different writers that use different language to talk about the different phases of group development, different authors and writers use different language to talk about the different phases of trauma recovery. And this framework goes all the way back to Pierre Janet in 1889, so 130 years ago, who created a model for treatment of traumatic stress. And their model had 3 phases: stabilization, identification, and relapse prevention. This 3-phase model has been mirrored and echoed throughout many other trauma experts and their writings and frameworks for treating trauma. In 1992, we have Judith Herman's famous book on trauma and recovery, and Herman describes the 3 phases as establishing safety, remembrance and mourning, and reconnection. In the seeking safety model, these phases are described as safety, mourning, and reconnection. Christine Courtois and Ford, in their 2016 book, Treating Complex Trauma, they articulate the phases as safety, stabilization, and engagement as phase 1, processing of traumatic memories as phase 2, and integration or reintegration as phase 3. Therapeutic spiral model of trauma-focused psychodrama describes phase 1 as being focused on prescriptive roles in psychodrama, focused on accurate observation, containment, and strengths. Phase 2 gets focused on trauma-based roles in the psychodrama, dealing with victim roles, perpetrator roles, abandoning authority roles. And phase 3 is focused on transformative roles in psychodrama, roles related to autonomy, integration, and correction. EMDR, trauma-focused CBT, they also have similar 3-phase models based on stabilization, reprocessing of traumatic memories, trauma narrative in phase 2, and integration consolidation in phase 3, or future templates in terms of EMDR. Now, across all these 3 phases, there's some similarities. Phase 1 tends to be very here and now focused on the present moment. Stabilization, psychoeducation, safety, relationship building, psychoeducation, considering our here and now feelings, sensations, and how the trauma from the past is impacting us here and now. Phase 2 usually orients on the past, and in trauma processing, it's on the past trauma in many cases. Whereas phase 3 tends to look to the future, that where are we growing? What direction are we growing in What are we looking towards in terms of the future, our goals? What are we trying to integrate in terms of moving towards a vision of ourselves in recovery from trauma? So present, past, future. So I want to encourage you to consider which of these clinical map phases do you feel best able to facilitate a client or a group in your work? And which of these clinical map phases do you feel like gets most overlooked in your work? How does your program or agency incorporate each of these clinical map phases into the services that are offered? Sometimes we can create groups that are more focused on one phase rather than other phases, and that can meet trauma survivors where they're at in different aspects of their trauma recovery process. For example, you might start a trauma group that's more focused on phase 1, about psychoeducation, safety, coping skills, grounding, relationship, that intentionally does not go into trauma processing. Or you might start a trauma group that's focused on phase 2, that's focused on trauma processing. But you would need to make sure that you screen out participants in the group who are ready for that phase 2 work. And we need to be sure that our trauma treatment programs are also addressing phase 3. This is the one that I feel like gets most overlooked in the field. That sometimes phase 1 gets overlooked and people want to just dive right into trauma processing and talking about the trauma. But I think nowadays we do a good job of that strengths-based focus and establishing safety before getting to the trauma work. But this third phase often gets overlooked, that we need to consider post-traumatic growth, integration, transformation, and where are we going from here? What does trauma recovery look like, rather than only focusing on what the trauma looked like? So the next section in Chapter 2 goes into outlining how Moranian philosophy is inherently a trauma-informed philosophy. And so it's important to keep in mind that Moreno created his philosophy and his theories nearly 100 years before SAMHSA published and organized trauma-informed care. So, this is going back to the 1920s, 1930s. It wasn't until 1980 that PTSD was recognized as a diagnosis. And then it wasn't until 2014 or so that SAMHSA was really putting out publication after publication, organizing trauma-informed care and trauma-informed principles into a package of sorts. So Moranian philosophy didn't get to benefit from all the new information about trauma, about neuroscience, about trauma-informed care and trauma therapies. None of that language was around 100 years ago or 80 years ago when Moreno was creating his ideas. Nevertheless, Moranian philosophy really embodies trauma-informed care philosophies in a couple different ways, in many different ways, really. Just like trauma-informed care philosophy, Moranian philosophy is very humanistic. It's person-centered, it's strengths-based, and it really challenges the medical model approach to conceptualizing individuals. Moreno believed that we had to consider the larger systems and social forces that individuals are a part of, and how these larger social forces had an impact on their health and well-being. Moranian philosophy is holistic in that it considers the entire person, all aspects of the person, from their body to their psyche, to their spirit, their relationships, and to the culture within which they live. So Moranian philosophy is inherently a holistic philosophy. Now, many people don't realize that Moreno was the first to create a body-oriented psychotherapy. So psychodrama was the first body-oriented therapy, and it emphasized action over talking. Moreno argued that the body remembers what the mind forgets, and this was 70 or 80 years before Bessel van der Kolk and others started talking about the body keeping the score. Moreno's philosophy emphasizes action over talking. He says that the word or talking or thinking or analyzing something can only happen after action. That action always predates any kind of analysis. So he emphasized the importance of action and acting out our problems and solutions and then after the action, coming back to the integrative part. So while psychodrama and Moranian philosophy may appear to emphasize catharsis and the expression of heavy emotions, and it does at times, Moreno also argued in his philosophy that abreactive catharsis alone was not healing, unless it was followed up by a catharsis of integration, unless there was some sort of transformation, some integration, new perspective, cognitive restructuring that took place after the catharsis. So this inherently follows that three-stage clinical map that we talked about earlier, that after trauma processing and catharsis, there needs to be some kind of integration. The Moranian philosophy really emphasizes this. Even the three phases of a psychodrama group seem to really mirror the three phases of the clinical maps for safe and effective trauma therapy. Phase 1 of Moreno's method is about warming up. And this really coincides with phase 1 of the trauma clinical maps that focuses on establishing safety, providing connection, psychoeducation, coping skills, really engaging the group in kind of lighter, gradual way before we move into the more difficult stuff. Phase 2 of Moreno's framework is action, where we would do a psychodrama of some sort. This is where we would get into addressing the issue at hand. This is where the catharsis of abreaction would occur. This is where, intense emotions could be processed, trauma could be addressed, feelings could be released, anger, sadness, or fear, or rage. But Moreno highlights that phase 3 is about sharing and about integration. This is after the psychodrama. The group would come together, de-roll from the roles they played, and share about how that experience was for them. And many of the new insights, new perspectives, and the cognitive processing, restructuring, comes in the sharing phase, which seems to mirror that third phase of the clinical map for safe and effective trauma work that's focused on integration. The Moranian philosophy seems to really emphasize and articulate many of the trauma-informed care philosophy that came 70, 80, 90 years later. Although Moreno didn't have the language to talk about trauma or PTSD, most of his work was actually with trauma survivors. He worked with sex workers, he worked with refugees, with immigrants, he worked with children, he worked with inmates in a prison, he worked with youth at a boarding school, and then later when he opened up his mental health hospital, he worked with folks that were experiencing really severe mental health issues, such as psychosis and schizophrenia. So Moreno's work was mostly with trauma survivors, and so it would make sense that his philosophy might reflect trauma-informed care philosophy to develop decades later. So it's important that we consider theories and philosophies. Many times as practitioners, we tend to focus more so on the interventions and skills and competencies while overlooking underlying theories and philosophies. And at the end of his life, Moreno was really upset that his methods had become really popular, but the underlying philosophy from which his methods came had been separated from the interventions. That people were using role-playing and doubling and role reversal and empty chair and sociometry and sociodrama, but they weren't using it in conjunction with his underlying mysticism, his philosophy, and his theories. He actually describes it in his autobiography as tearing a child away from its parents. And so he really thought it was important that when we're practicing psychodrama, that we're using it in conjunction with the underlying theories and philosophy from which the methods came from. Now, there's a quote I found in an article by Mullen Lezik from 2018 that I really like, that I think summarizes the importance of theory compared to techniques or interventions. Mullen says that theory teaches us where to head therapeutically, and technique teaches us what to do once we arrive there. So it's almost like the theory provides the compass of where we need to go, provides a map of what needs to be done, and where our journey is going to take us. And then the technique are the tools that we use to do the work once we get there. And so if we don't have a compass or a map, a sense of what kind of journey we're going on or where we're headed, we're going to start using all sorts of tools and techniques out of context when they're not really needed, when they might cause harm, or when they just might not be most effective. So it makes sense that theory and technique be used in conjunction with each other. I think this is one of my biggest criticisms of not just the way psychodrama has been used, but of therapists in general. I find that many times if I ask a therapist what theory they're conceptualizing their cases from, what theoretical orientation they're working from, many therapists don't have an answer. Of course, many therapists do have an answer to that, and they're really clear about what theories they're using and how they're conceptualizing their cases. But it's alarming that many therapists at the same time don't know what theories they're working from and aren't working from any theories. They're doing whatever feels right in the moment, which is prone to error. Of course, we want to trust our clinical intuition and wisdom, but if we're only doing what feels right with the client in the moment, we're also really prone to acting on bias, countertransference, and projection, which is likely to lead to re-traumatization or just not be helpful for clients. So having a balance of theory while also trusting our intuition within the framework of that theory and the techniques, I think is the safest way to provide therapy and especially to treat trauma. So I want to challenge you for a moment to consider, how do you use theory to guide your therapeutic approach and interventions? Which theories are you using to guide your interventions? So another key part of Moreno's philosophy is this mystical concept that he describes as the autonomous healing center within. And both Jacob Moreno and Zerka Moreno highlight this as one of the most important aspects of psychodrama philosophy. Zerka says that the purpose of all therapies, including psychodrama, is to clear away some of the barriers that prevent the client or the protagonist from tapping into and accessing their autonomous healing center within. That our task as therapists or as psychodramatists, as group workers, is to lead the client and help them clear away some of the things that are preventing them from healing themselves. So this concept is really self-empowering, really embodies some of the 6 trauma-informed principles for this to be really the crux of psychodrama philosophy. It helps promote safety in that it's relocating the power, the leverage, the place from which change comes from within the client rather than within the therapist or the organization or the agency. We're not agencies or therapists providing a medication or providing a treatment to a client, but that we're helping clients access the medicine which exists within them already. We're helping them tap into their autonomous healing center. Moreno describes this autonomous healing center as existing deep within the self, and that it's largely untouched by words and can be activated and accessed through action. So this autonomous healing center is what we're trying to tap into and help our clients, our groups, access. The Morenos talk about how, as therapists, as providers, as leaders, we aren't going to be able to help our clients tap into this autonomous healing center unless we first learned how to tap into this within ourselves. That we have to do our own personal work, our own healing. We have to be able to locate and access and tap into our own spontaneity, creativity, and our own autonomous healing center within in order to help a client to do the same. So there's a big emphasis in psychodrama training and in the psychodrama culture and community in professionals doing their own personal growth work. And it's a part of just about every psychodrama training. This autonomous healing center concept, it really dismantles some of the power dynamics that are usually inherent in the client and therapist relationship. It positions the locus of power, therapeutic power, within the client rather than within the therapist or within the relationship or the agency. It explicitly tells the client that they're the source of their own healing, that we're just here to guide them and to help them tap into that for themselves. So this concept of the Autonomous Healing Center, it also really embodies the importance of peer support, which is the third trauma-informed principle. It really positions the therapist, the client, the protagonist, and the rest of the group all as peers. That we're all human beings. We all have one Autonomous Healing Center within us. We can only tap into our own, and oftentimes we need each other to help us remove some of the barriers so that we can heal ourselves. In psychodrama groups, after the psychodrama action, and when we move into the sharing process, it's actually pretty common for the therapist or the psychodramatist to share personally from their own experience about how they relate to the protagonist in the same or similar way that the rest of the group does. That we explicitly acknowledge that the therapist, the psychodramatist, is part of the group, not above the group, and that we're human and that we're within the group. So it really embodies this principle of peer support from trauma-informed care. The belief in an autonomous healing center also promotes collaboration and mutuality, which is the fourth trauma-informed principle. It highlights this sense of reverence and respect for each person, a belief, a strong conviction in the goodness and the power, the healing potential within every client, no matter what they've experienced, what they're struggling with, who they are, what their background is, that we believe this exists within every client. The idea of the Autonomous Healing Center also cultivates the fifth trauma-informed principle of empowerment, voice, and choice, in that it really highlights a respect for the client's voice, believing that the client can find and tap into their own autonomous healing center when we give them choices and honor their choices, that we follow the protagonist throughout the psychodrama process, and that we're trying to empower them to heal themselves, to tap into their own autonomous healing center. So this concept is really embedded within many different cultural belief systems, many different religious belief systems, and it's a new idea. It's something that many indigenous philosophies subscribe to, many mystical philosophies and spiritual traditions, religious belief systems suggest a similar idea. And perhaps Moreno was inspired by all the different religions that he studied when he came up and articulated this idea in a psychotherapy context. So we not only believe that an autonomous healing center exists within each individual, but that it also exists within each group, within each community, each family, each organization, and within society as a whole. And so as group workers, psychodramatists, our task is to cultivate that peer support and mutual aid that helps the group to tap into their collective autonomous healing center, the healing power of the group as a whole, or the healing power of the organization as a whole, the community as a whole, or within all of society. So this concept really emphasizes that every participant in the group, every part of an organization, of a community, each human within society is a therapeutic agent for every other person in the group, community, organization, or society. So in thinking about this concept of the Autonomous Healing Center, I want to challenge you to reflect on how might you further empower your clients as co-healers in their own treatment process? And how can you further affirm the dignity and worth of each client and each colleague, each community member that you work with? How can we really demonstrate in action our commitment to this belief in the healing power of each person? Again, this concept is not new, and you can find this articulated in other language and other trauma therapies. For example, in internal family systems approach, there's a concept called the self with a capital S. And the self is kind of this core aspect of an individual that's curious, that's compassionate, that's courageous and confident. And the healing of other parts often comes by unblending them and putting them in relationship to the self. Similarly, in EMDR, which is one of the top gold tier treatments for PTSD, there's this theory of change called the adaptive information processing model. And in EMDR, we believe that through the EMDR intervention and the bilateral stimulation, that we're helping a client connect an old traumatic memory that's been fragmented and disconnected from all the adaptive information within the self and within the brain. We're helping to connect that memory to all the adaptive information that exists within an individual. And that integration of the adaptive information into the traumatic memory network provides a experience of healing, that the client's brain is healing themselves. And we could call it the adaptive information processing model. We could call it the self in IFS, and we could call it the autonomous healing center in psychodrama. And I'm sure there's other approaches that have different names for it as well. In psychodrama, the approach is unique in other ways. One other way it's unique is that we emphasize the importance of play and the importance of spontaneity and creativity. So the founder of psychodrama, Jacob Moreno, his tombstone in Vienna, in German, it says, "The man who brought joy and laughter into psychiatry." So Moreno really believed in the healing power of humor, of play, of joy, and of laughter. His approach is very strength-based and in alignment with positive psychology features. And there's been a lot more research and theories coming out about the importance of play in the trauma healing process. Some have suggested that play promotes a sense of safety. It helps to cultivate relationships. It provides a sense of connection between two people or multiple people. Play gives individuals a sense of control over their environment through the games that are played. And it helps us connect to a sense of joy and aliveness, spontaneity. So psychodrama's emphasis on spontaneity and role playing inherently emphasizes the importance of play. In one of my trauma-focused psychodrama research studies, one of the qualitative themes we found in survey responses from the inpatient participants in the group was that they were surprised that they could have fun while doing trauma therapy in the psychodrama group. And this feedback came up multiple times, and it continues to come up in my ongoing line of research on trauma-focused psychodrama, that the participants have fun and enjoy themselves while doing trauma therapy, which isn't always the case for other trauma therapies that can be pretty intimidating and even intolerable at times, have higher dropout rates perhaps. There's an author in 2018, Gross, who has a quote about play and trauma that I thought was just spot on, and I wanted to read it to you. I quoted it in this chapter in the book. Gross writes that, in many ways, play is the opposite experience of trauma. While play brings about feelings of joy, trauma brings feelings of hopelessness and despair. While play serves to unite us, trauma serves to isolate us. While play motivates us to actively engage in the moment, trauma motivates us to fight and flee from the moment. And while play allows us to control our environment, trauma occurs when our environment controls us. Play has the potential to serve as an antidote and powerful corrective emotional experience to trauma when integrated into the treatment. So psychodrama is one of the approaches and one of the theoretical orientations that explicitly integrates and emphasizes play in the treatment process. Psychodrama's theory of change is spontaneity-creativity theory. And we define spontaneity as this energy that occupies us, that allows us to feel a sense of freedom and vigor and focus, and that it allows us to have new responses to old reoccurring situations and adequate responses to novel situations that we're faced with. So you could think of spontaneity as this sense of life energy that gives us a competence for life, for facing life's problems and dilemmas, and finding creative solutions to them. Rhino has this whole map called the Canon of Creativity that outlines the relationship between spontaneity and creativity and really highlights the importance of the warming up process. So the Canon of Creativity is a circle with a line in the middle of it. And so the circle represents the warming up process. That we start with all the cultural conserves, all of the ideas and things that already exist, and we use these as a warming up process. And at some point in our warming up process, we tap into a spark of spontaneity. And when the spontaneity is accessed, it's met with creativity. That spontaneity and creativity are twin concepts, that they gravitate towards each other. And that spontaneous energy with that creative force results in the creation of something new. A new belief about ourselves or about the world, a new theory, a new treatment approach, a new piece of art or music, a new policy in an organization, a new publication, a new idea, a new role within our lives, a new coping strategy, a new response to anger or sadness, a new way of being in the world. And as soon as something new is created, it becomes a part of the cultural conserve that's available to us. And we use that cultural conserve and all the others to warm up to new spontaneity and creativity. So this is the canon of creativity. It's a map for change. And you can think of it as a map for change on a intrapsychic level, on a interpersonal level in relationships, on an organizational level, and on a societal or communal level. That if we're going to try to cultivate change, we need to first engage in a warming up process and engage everybody that's involved in a warming up process. That if we want to develop some sort of new policy in an organization, for example, the policy will be much easier accepted if we warm up the group, the organization, to that new change. We have discussions about the policy. We collaborate and fine-tune the policy. We get feedback about the policy. And in doing so, we're engaging in a warming up process. We start to highlight the importance of having a new policy. We outline a timeline for when the policy is going to be implemented and what it's going to, how it's going to impact people. And then we implement that policy. We create the change. Versus if we were to create this policy behind closed doors without warming up the rest of the organization and the staff to the policy change, and then just send out an email and make an announcement that, hey, guess what? There's a new policy and now y'all have to follow it. There's going to be much more resistance, much less compliance with the policy, and it's going to be much more difficult to roll out that new policy. So this warming up process is a really important aspect of psychodrama philosophy, and it's something that I feel like gets overlooked quite often in other approaches. That we can't just engage in a psychodrama without engaging in a warming up process. We can't just dive into trauma therapy and trauma processing without first engaging in a warming up process. In psychodrama, we say there's no such thing as bad role plays or psychodramas. There's just poor warm-ups to it. And we also say that there's no such thing as resistance. Instead, we reconceptualize resistance as either a lack of warm-up or that somebody's just warmed up to something else. So we really look at resistance through the lens of a warming up process or lack of a warming up process. So the warming up process is the operationalization of spontaneity. And from what I've seen clinically and in my research, what I'm noticing is that trauma survivors, compared to others, are going to need a longer warming up process, a more gradual warming up process, a gentler warming up process, that we can't just dive right into the intensity of the work. There needs to be a more gradual warm up to that and a more gradual process of developing safety, really. My research is showing that there's an inverse relationship between PTSD and spontaneity. That when PTSD symptoms are high, spontaneity is low. And that when we increase our spontaneity or help our clients increase their spontaneity, their PTSD scores drop at a similar rate. And in 2022, I published the first study on PTSD and spontaneity. It was a controlled research study on a 3-day psychodrama group. And we found that the control group, their PTSD and spontaneity scores and their post-traumatic growth scores stayed pretty similar, whereas the experiment group that participated in the psychodrama groups, their PTSD scores dropped, and as their scores dropped, their spontaneity scores and their post-traumatic growth scores increased. Interestingly, in that study, we found that the scores in the days after the workshop, although there were some changes, the changes were far more pronounced at our 30-day follow-up than they were just in the days after the workshop, suggesting that spontaneity and post-traumatic growth might take some more time to cultivate and set in an intense psychodrama experience. The individuals might need some time to process and digest the experience. Moreno theorized 100 years ago that spontaneity and anxiety would be inversely related. And now there's been multiple studies confirming this. And a whole bunch of different studies on spontaneity showing that it's inversely related to other mental health issues such as depression, anxiety, panic disorder, PTSD now. I have a new study where we found it inversely related to traumatic grief as well. And there's also been a bunch of research on spontaneity showing that it's positively related to a whole bunch of measures of well-being and health. That as spontaneity increases, so too does overall well-being, happiness, and mental health. So in psychodrama, spontaneity is really the most important thing. Spontaneity is the curative factor in psychodrama. So through the lens of spontaneity theory, we could conceptualize PTSD, post-traumatic stress disorder, as being either a deficiency in spontaneity, that there's a rigidity and a stuckness, a lack of access to spontaneity in the aftermath of trauma, which leads to repetition, compulsions, reenactments, hyperarousal that prevents us from tapping into creativity, and or that spontaneity or that PTSD is also characterized by a sense of pathological spontaneity. So pathological spontaneity is when we have novel responses, but that they're not adequate to the situation at hand. So you could think of pathological spontaneity as being the opposite of rigidity or stuckness. It's essentially a sense of chaos, really. And many other mental health experts are suggesting that chaos and rigidity, a lack of containment and over-containment, are two ends of a spectrum that characterize all social problems, all mental health problems, and that health, mental health, social health, physical health exists in the balance between them. In spontaneity theory, we would say that healthy spontaneity exists in the balance between pathological spontaneity and a deficiency in spontaneity. So this is how we might think of and conceptualize PTSD through the lens of spontaneity theory. Through that lens, then, our goal would be to help clients tap into their spontaneity, to engage in a warming up process that's gradual and meets them where they're at, so that they can access that autonomous healing center within, and in doing so, tap into their spontaneity, their creativity, and develop new ways of responding to their trauma, of renegotiating the way the trauma lives within them. To cultivate post-traumatic growth through a spontaneity state and through a creative response to the trauma, a new response. So at this point, I want to pause and offer some reflective questions. The first question here is, does my facilitation approach and the group structures I use provide enough emphasis on the warming up process? How do I warm myself up to lead a group or to lead a meeting? So before we engage in a warming up process, or try to warm up our clients or colleagues or group members, we first have to warm ourselves up as facilitators and as leaders. So in what ways can I promote a warming up process for myself? And what ways can I help my organization warm up before I'm implementing any major changes? So next, I want to talk a bit about catharsis and about action theory and the different phases, elements in a psychodrama and role theory. So we're going to go through some of psychodrama's core theories next. So many have suggested that Jacob Moreno contributed to the theories about catharsis more so than anyone since Freud and Brewer in their publications about hysteria. So Moreno differentiates different types of catharsis. He talks about a catharsis of abreaction and a catharsis of integration, audience catharsis and an actor catharsis. He highlights the way that catharsis is contextualized within relationships and within a social experience, and that there's a reciprocity in terms of our social experience and catharsis, that when we see someone else having a catharsis, that it fuels our own experience of catharsis. This was described previously, but it's important enough to describe it again, that the catharsis of abreaction describes the expression and release of emotions, oftentimes anger or sadness, and that a catharsis of integration is taking in something new to replace what was released. Oftentimes this is a much quieter catharsis, and it happens on a cognitive level as well as a somatic and emotional level. The catharsis of integration is really the goal, the end goal of a psychodrama. Many times before we get to a catharsis of integration, there has to be a catharsis of abreaction. We have to help a client let go of something and release something so that they can take in something new and have that integrative experience. But it's important that we don't forget this integration. We can't just provoke intense catharsis in our clients and expect that by itself to create change, unless it's followed up by integration. In Moreno's development of psychodrama, early on in the 1920s, he created what he called the theater of spontaneity. And his idea was that he wanted to try to provoke catharsis in large groups. And at that time, he decided that the theater was the best way of creating social change on a larger scale. So he created the theater of spontaneity, where his actors would go on stage, and they would take stories from the audience or from the local newspaper, and they would spontaneously enact these stories in front of the audience, attempting to provoke catharsis within the audience. He believed that if he could provoke this catharsis in the audience, this emotional experience, that he could help cure some of the social, emotional, psychological, mental health problems within the community. In this process, what he noticed was that not only was the audience having catharsis, but his actors were also having a cathartic experience when they were role-playing. And so he started to experiment with assigning his actors different roles based on what he knew about their personal lives, their personalities, their own personal struggles, and their own experiences. And he noticed that when he assigned his actors a role on stage in the theater that seemed to correspond with personal roles in their own life, or he put his actors into situations in the theater production, the role play, that seemed to symbolically represent situations that they were in their own personal life, that the actors were having a stronger catharsis. This was some of the beginnings of his ideas about psychodrama, role-playing in therapeutic and clinical contexts. He also noted that there's a relationship between spontaneity and catharsis, that when we experience something for the very first time, our catharsis is the strongest. And that if we replicate that experience again and again, each time our cathartic experience gets diminished a little bit and a little bit and a little bit. One way of thinking about this, depicting this, is think about the first time you saw your favorite movie that you felt emotionally connected to and had an emotional catharsis during. That the first time you saw that movie, your catharsis would have been the strongest. And that each time you rewatched that movie, your emotional catharsis would be slightly less as strong as it was the first time. Each time you watched it, the catharsis, it might still be there, and you might notice other things in the movie that you didn't notice previously, but the emotional release gets a little bit less and a little bit less and a little bit less. So there seems to be a relationship between spontaneity and between catharsis, that when something happens spontaneously in our life or in therapy, we have a stronger cathartic release than if we planned out all the details of something and then experienced it. It wouldn't be as spontaneous, and thus our catharsis wouldn't be as strong. Moreno also highlights how there seems to be a relationship between action and catharsis, more so than just talking and catharsis. In a 1950 publication, Moreno writes that the greater catharsis is achieved through action is undeniable. The patient is able to express kinesthetically many feelings for which he has no words. So here Moreno is talking about bringing the body into treatment, and how in action and involving the body, the nervous system in the therapy, such as in psychodrama, that our participants can experience a much deeper and more powerful catharsis than if we were just sitting and talking about something. Zerka Moreno, in her book on psychodrama, Surplus Reality and the Art of Healing, she writes that many times the most healing of catharses happens in psychodrama scenes where we're role-playing experiences that are impossible in reality, but only possible in the surplus reality of a psychodrama. For example, many people might experience an abrupt ending in a relationship, and they might crave to have closure in that relationship. And that in psychodrama, well, in reality, they might not be able to have closure. That person may have died, or might not want to talk to them, or they might not be able to have a conversation with the person or people they need to for closure. But that in psychodrama, the impossible becomes possible. We can create a role-playing scene where the client can have that conversation and experience that closure, say the things that they need to say, express the feelings they need to express, and hear the things that they need to hear from the other person in order to have closure. And that in these types of scenes that are impossible in reality, but possible in psychodrama, many times the most powerful and healing catharses take place. There's another popular psychodrama author, Peter Felix Kellerman. He really summarizes Moreno's contribution to catharsis in the following quote from his 1984 publication. to include not only release and relief of emotions, but also integration and ordering. Not only intense reliving of the past, but also intense living in the here and now. Not only a passive and verbal reflection, but also an active, nonverbal enactment. Not only a private ritual, but also a communal shared rite of healing. Not only an intrapsychic tension reduction, but also an interpersonal conflict resolution. Not only a medical purification, but also a religious and aesthetic experience. So here, Kellerman is highlighting the difference between catharsis of abreaction and a catharsis of integration, highlighting the differences and how they need to complement each other. So these are some of the nuanced ideas related to catharsis in psychodrama. Like I had mentioned, Moreno really believed that the stronger catharsis is going to take place in action. And this leads us right into talking about Moreno's action theory. He believed that when we're harmed or hurt in action, that the healing must also come in action. That if we're hurt in action, we can't heal just by sitting and talking. That we have to experience the healing in action as well. And this action theory, it's pretty simple, and it's really based or really supported by a lot of the new neuroscience findings. So most neuroscientists agree that the greatest neuroscience finding of the century is that the brain maintains its neuroplasticity, its ability to change, throughout the entire lifespan until we die. Not just throughout our childhood and adolescence until we're 23 or 25 years old when the brain structure stops growing, but throughout the entire lifespan, our brain is constantly changing based on experiences that we have. That experience is what changes the brain. And that just like past trauma can change the brain, so too can new healing experiences. So psychodrama and action theory really proposes that the importance of providing new corrective experiences, corrective emotional experiences, relational experiences that can offset and renegotiate past damaging experiences we may have had. Classical psychodrama theory and philosophy has a simple slogan, perhaps, that's depicted as do, undo, and redo. And this describes the trajectory of connected psychodrama scenes. That in classical psychodrama, we would get a protagonist from the group. We would have them, through self-presentation, demonstrate and act out the issue they're experiencing. That's the first part of it, do. Then we would change what was going on. We would try to undo the problem. We would prevent the harm. We would give the protagonist a chance to interfere and create some sort of change within that scene rather than just reenacting it again and again. And that's the second part, undo. Oftentimes this involves revisiting older memories, older experiences, and looking at the source of some of the problems that in the here and now that are connected in larger memory networks. And oftentimes we have to revisit those touchstone memories to look at the here and now dysfunction. So we do, we undo, and then we redo. And the redo describes the final psychodrama scene where we would provide some sort of rehearsal or role training for the future. Next time you find yourself in this situation, how can we respond differently? And let's practice that response. Let's practice it a bunch of different ways. Let's get the group to help you experiment with different ways of being, of redoing this situation in a new way. So do, undo, and redo. And it's all done in action. The sharing, the analysis, the processing, all of that happens afterwards. But the action is the core part of psychodrama, and action theory is a core part of psychodrama's theory. So remember, warm up is the first part of the group, then the action, the psychodrama, and then the sharing and the talking. In psychodrama, we have 5 different elements. The first is the director or the facilitator. The second is the protagonist. The protagonist is the individual who's the center of the psychodrama, whose issue and goals we're putting into action. The third is the stage. And although Moreno often worked on a circular stage, in modern psychodrama, we usually just use the space in the middle of the circle of chairs in the therapy group as the stage. The fourth element is the auxiliary roles, the auxiliary egos. So these are the other roles and the role players that play the roles that are needed in the psychodrama scene. So, for example, if we were to do a psychodrama scene with an individual talking to their partner, we would ask them to choose someone to play the role of their partner. And that would be an auxiliary role. And the fifth element in psychodrama is the audience. So the audience are the group members that aren't in roles, that are observing and bearing witness to the psychodrama and the healing. So these are the 5 elements in psychodrama. So in those 5 elements, there's lots of different roles. We have the director role, the protagonist role, the auxiliary roles, and the audience roles. And that's a nice little segue into the next psychodrama theory that's important to highlight, which is role theory. So role theory is psychodrama's theory of personality. In role theory, we really find a non-pathologizing way of conceptualizing mental health and the individual. That the self is composed of all the roles that one plays in their life, and that a healthy personality has a wide enough role repertoire to shift between different roles and role behaviors to have a spontaneous and adequate response to the situation at hand. Role theory is a really simple way of conceptualizing behavior, and it provides a bridge between theater and the arts, sociology and psychology and religion, and just a really simple way of talking about parts of self. In psychodrama theory, there's 3 different types of roles, and actually 3 different selves that correspond to those categories of roles. The first are somatic roles. These are body-based roles related to physical postures, physical behaviors, and actions. These are the first roles to emerge in an individual's development as an infant. Things like the role of the eater, or the role of the drinker, or the role of the walker, or the role of the sleeper. These somatic roles become more and more sophisticated as we develop emotionally and psychologically and socially, but that these are the first roles to develop. That before we have a psychological or social sense of ourselves, we first are developing a somatic sense of ourselves. And so all of our somatic roles together, combined as a collective, the sum of them would be our somatic self. Second category of roles are psychological or psychodramatic roles. And so these are the roles within ourself, the roles within our dreams, the roles within our imagination, the roles that we act out through play or role-playing. These are roles that are more psychological in nature, that are more related to imagination and dreams. Roles that we see and experience ourselves in internally. And the sum of all of our psychological or psychodramatic roles equals our psychodramatic self. The third category is social. And so we all have various social roles, and that the collection of all of these social roles equals our social self. And then together, the integration of these three selves, our somatic self, our psychodramatic self, and our social self, equals our personality. So role theory provides a really simple way of conceptualizing the self and parts of self. And it's a simple idea, the role, simple enough that it translates from language to language, from culture to culture, that the idea of a role is easy to understand and easy to describe to really anybody. And that roles, although they might be similar cross-culturally, they also manifest differently in different cultures. So, for example, the role of teacher. You can find this role in any culture, in any society and community. You can find examples of people in the teacher role. But the actual behaviors, the presentation, the norms, the boundaries attached to the teacher role are going to look slightly different from culture to culture, even though the core aspect of that role is going to remain the same. Many times roles emerge in relationship to others and in relationship to other roles. So in role reciprocity, perhaps. So with that example, the role of the teacher, the reciprocal role would be the role of the student. So there's no teacher without a student and no student without a teacher. That these roles are interdependent on each other. And that our parts of ourselves, our roles in our life, are developed in reciprocity to other roles that other people hold in relationship to us. So it's a very interpersonal and dynamic way of thinking about personality development. Roles not only emerge in relationship to others, but also in relationships to situations, in relationships to society and social forces, and are contextualized within the culture that we live in. There's 3 different phases of role development. And so this is an important concept, part of role theory is role development. The first phase is role taking, the second phase is role playing, and the third phase is role creating. So in the role taking phase, this is where somebody is approaching a new role and considering stepping into a new role, starting to dip their toe into a new role. For example, if we take the role of teacher that I've been talking about, when I started moving towards this role for myself as a teacher, I was ambivalent about it. I had some resistance to it. I felt insecure and incompetent as a teacher. And I had lots of emotions I had to work out as I was in this role-taking phase. I had role models who I was mimicking and imitating, who helped me step into that role-taking as a teacher. So this is the first phase, and the dynamics emotionally, logistically, that characterize this first phase, role-taking. Next phase is role-playing. So this is after we've started to take the role, we start to find ourselves within the role and start to bring ourselves into that role. And we start to slowly, gradually tap into our spontaneity in the role. In the role-playing phase, we're able to competently hold that role. Now, we're still largely playing the role in the way that it was taught to us and the way it was role modeled to us. We're also starting to tap into some spontaneity. We're able to have adequate responses in that role. And then sometimes, for a role, we might move into the role-creating phase. So the transition from role-playing to role-creating involves accessing all of our spontaneity and creativity and expanding that role into something new, holding that role in a way that's entirely new and different than how it was taught to us and how it was role modeled to us. So, for example, after I spent some time in the role of teacher, I started to integrate different professional roles. For example, the role of being a trauma therapist, a psychodramatist, a group therapist, an organizational leader, a social worker, integrated these roles within myself as a teacher, and I started to offer trainings and teachings and videos like this and books that integrated all of my learning into something new that hadn't been created before, a new way of holding this role of a teacher. So this would be an example of stepping into role creation. So we have role taking, role playing, and role creating. Now, it's important to note that we don't always move through all three phases of role development. Sometimes we stay in a role-taking phase with a role. For example, for me, the role of dancer is one that I haven't gotten past the role-taking phase. I'm a horrible dancer. I really don't like dancing. I have a ton of anxiety about dancing and lots of resistance about it. And so I'm still in this role-taking phase. Anytime I need to step into the role of dancer, I'm not really in a role-playing phase. I'm still in this role-taking phase. Whereas there's other roles that we might move from role-taking into role-playing, but not quite move into a role-creating phase. For example, sometimes there's social or systemic forces that prevent us from changing a role. A simple example of this might be if you're working in an agency and you got hired to do a specific job, agency is saying, we're going to teach you and train you how to do this job, role taking. And this is precisely how we want you to be in this role and exactly what we want you to do. Don't do anything different. So they're saying, we want you to stay in a role-playing phase. We don't want you to be creative. We don't want you to be changing the role and expanding the role. We want this role exactly like this. And so that systemic limitation would prevent somebody from moving into a role-creating phase. So this is a really helpful way of conceptualizing our relationship to roles and a helpful way of thinking about what's next in further stepping into and integrating different roles in our life, as well as helping our clients to step into and integrate new roles into their life. We also can see the emergence and development of roles through these phases in a psychodrama session or in a treatment experience for a client. So, for example, if a client's treatment goal has to do with becoming somebody who's in recovery from trauma and addiction, this is the vision that they have for themselves, their treatment goals, just generally articulated. And they might enter treatment in a role-taking phase, where they're stepping into these new roles of being a person in recovery from addiction and trauma. Maybe there's some resistance, some anxiety, some insecurity and ambivalence about stepping into these new roles, integrating these new roles into their life, into their self. And they're going to need role models, and they're going to need people to help teach them these new roles and the behaviors associated with these roles. At some point, they might move into a role-playing phase, where they're able to bring themselves into the role of somebody in recovery from addiction and trauma. In the recovery communities, they often say, fake it until you make it. Almost like, just play the role. Act as if you're somebody in recovery. Think about, what would somebody in recovery from addiction or trauma do or think or say or feel in this situation? So step into that role-taking and role-playing phase. And then this role-playing phase, oftentimes it's characterized in recovery by following really rigid norms or ideas about what recovery looks like in a very specific context or program. And then the role-creating phase would then look like creating your own personalized way or manner of being a person in recovery from addiction and trauma. That you're no longer just mimicking what your role models did or how someone taught you how to be in recovery, or role-playing, acting as if, faking it until you make it, going through the motions prescribed by a certain approach or program, but that you're really bringing yourself fully into these roles, and you've created a new way, a unique, personalized way of being a person in recovery that fits you, bringing all your spontaneity and creativity into it. So these 3 phases of role development can be really helpful in organizational settings, in personal and professional development, and in treatment contexts. So some questions to reflect on related to these theories. Which phase of role development am I currently in when it comes to being a trauma-informed professional? So this book is all about trauma-informed care. When you think about your development and the evolution of your process of becoming a trauma-informed professional, or even more specifically, a trauma-informed group therapist, or a trauma-informed psychodramatist, or a trauma-informed organizational leader, which phase of role development are you in? Are you role-taking? Are you in that role-playing phase? Or have you moved into a role-creating? And what might you need to do to move to the next phase? So next, I'm going to briefly talk about Moreno's developmental theory. So Moreno outlines different developmental phases which correspond to the different interventions that we use in psychodrama. He had this mystical belief that there were 2 separate universes, the first universe and the second universe, and that these universes intersect. And he has this symbol that looks like this, kind of like the Under Armour logo. 2 half circles that overlapped with each other to describe and symbolize the intersection between the first and the second universe. So he believed that when we're born into this world, that we're coming into this world, the second universe, by way of the first universe. He describes the first universe as a place of timelessness, of formlessness, spacelessness, where all things are sacred, where the Godhead exists, a place of pure spontaneity and creativity. And that we're thrust into the second universe, this universe of form, of space, of time, of cultural conserves and limitations. And that when an infant's born into this world, they're in this state of consciousness called the matrix of identity. That a child does not have a sense of self when they're born. That doesn't develop until a bit later in their timeline. But that at birth, they exist in this state of oneness with not just their caregivers and parents, but also with the entire world, the universe, and everybody, everything within it. That there's no differentiation in terms of identity. Instead, there's a matrix of identity. And that the first phase of Moreno's developmental process is the doubling phase. This is where caregivers of an infant, when they're attuned to the infant, would offer doubling that would help a child give voice to what they're feeling, what they're experiencing, help them label internal sensations and feelings and experiences. And that when somebody doesn't grow up with accurate and attuned doubling from others, that they might feel this sort of fracture that happens within the self and this sense of being out of attunement and out of sync with others and with the way they're experienced by others and with the universe. That a lack of doubling early on in one's life can lead to a difficulty articulating one's wants, a difficulty articulating their needs, a difficulty expressing or labeling emotions. So this doubling phase is particularly important. The second phase of child development is the mirror phase. So this is where the sense of self starts to emerge in the infant's development, that the child can look at themselves in the mirror and see themselves and recognize themselves. They start to separate themselves from others psychologically, and they can start to develop a sense of individual personality. And so a child whose developmental needs are not met in this stage might struggle with a sense of enmeshment or codependency with others, or a really distorted sense of themselves. They might not be able to see themselves clearly. The third phase of Moreno's child development is the role reversal phase. And so this is where the child gets to a point where they can psychologically imagine what somebody else might be seeing, thinking, hearing, or experiencing. They start to develop a sense of other people's experiences and feelings and perspectives. So a child that experiences trauma at this phase might struggle with the capacity to consider other people's experience. They might be stuck in their own way of thinking or doing or seeing or experiencing things, and might not to have a rupture in their development of empathy or perspective or consideration for others. So these were the three phases of Moreno's developmental theory. Zerka Moreno expanded this original theory to include different phases throughout the entire lifespan, modeled after Erikson's psychosocial stages of development. Zerka's expanded version of the theory, it highlights how oftentimes the child becomes an adult after going through these three phases, and then is often tasked with helping their caregivers or their parents cycle through these phases as they prepare to die and as they prepare to return to the first universe, to leave this second universe and return to where they came from on a mystical level. That the adult child is often offering doubling for their aging parent, helping the parent to articulate their wants, their desires, their needs, to label their feelings and drives as their cognitive abilities start to decline. That the adult child is often providing a sense of mirroring, helping their parent, their aging parent, accurately see themselves and the changes that they're experiencing in the aging process. And that the adult child often must role reverse psychologically with their aging parent to see things from their perspective, and vice versa, to help them transition back to the first universe. So there's a really cyclical process of life outlined in Zerka's expansion of the developmental theory. So the developmental theory is all based in relationships, and it highlights how we develop and our sense of self emerges in relationships to others. Now, related to that is psychodrama's theoretical orientation around sociometry, sociometric theory. So remember, psychodrama is a triadic system. It has three parts: sociometry, psychodrama, group psychotherapy. So Jonathan Moreno, who is the son of Jacob Moreno, he has a really powerful quote. He says that psychodrama without sociometry is blind, and sociometry without psychodrama is sterile. And so we really need to be using sociometry and psychodrama together. And so along with that, it means that we need to be conceptualizing and using psychodramatic theories along with sociometric theories together. So one of the core sociometric theories is called the social atom. And the social atom is basically a way of thinking about and visualizing the individual within their social environment. The social atom really operationalizes social work's person and environment theory. The social atom is an exercise you can do with clients or with yourself, where you draw yourself in the center, and then you use different shapes to draw other people close to you in your life, surrounding yourself. And you would draw these shapes based on size, based on proximity to you, based on the amount of space they take up in your life. Traditionally, you would use triangles for males, circles for females, but I think we can all agree that that's pretty outdated and not very inclusive in terms of gender. So I encourage you to use whatever shape feels right for each person on the social atom, and to encourage your clients to use whatever shape they feel like for each person, rather than using that binary system that is often taught for drawing social atoms or genograms. So the social atom, once somebody draws themselves and all their relationships surrounding themselves, you end up with a visual depiction of one's social experience and their social life. And then we use lines, different types of lines, to connect the representation of the individual in the center of the social atom to others and the other shapes surrounding the individual on the social atom. Usually a straight line would indicate a connected relationship. Sometimes you might use a bold line to indicate a very connected relationship. A dotted line is often used to represent a lost relationship, and a squiggly line can be used to represent a conflicted relationship. So the social atom was created back in the 1930s, 1940s. It predates the genogram and the eco-map by several decades, and there's a pretty good chance that it influenced the development of the genogram and the eco-map, in that there were pioneers in family therapy that trained with the Morenos and then went on to become developers of different family therapy concepts, including genograms and eco-maps and social work, family therapy. The social atom can be used as an assessment tool, as an intervention, and as an evaluation, all in the same tool. You can have a client draw a social atom based on a representation of a moment in their past, based on their here and now experience in their relationships, or even based on what they'd like their social atom to look like in the future. So it's a really dynamic tool that you can modify for different situations. You could have a client draw a social atom here and now, and at the same time draw a social atom for their future, what they ideally would like their social life to look like. And then you can compare the two and use it as a map for depicting what needs to change in their social life. Many times I've done social atoms with clients, and just in 15 minutes of drawing a social atom, I gain more information and insight into their social life than I would have in months of verbally talking to them and asking them questions about their social life. It's a really useful and efficient tool for assessing one's social life. You can also modify it to include other things than just humans and social relationships on the social atom. For example, in substance use treatment, we might ask a client to not only put their social relationships on the social atom, but also to put their relationship with their drug of choice or other addictive behaviors on the social atom, and to symbolically represent how the relationship with drugs, with addiction, maybe with depression or anxiety, impacts their relationships. In eating disorder treatment, this is modified to include food or different types of food or eating on the social atom. You can also modify the social atom in strength-based ways. You could do a social atom focused on personal strengths. Draw yourself in the center and surrounding yourself the different personal strengths that you embody and tap into and demonstrate in your life. You could do it for different values or core values. You could do it for different groups or organizations, showing your relationship to the different communities that you're a part of, different groups or organizations you're a part of. You can even do it for different intersecting identities. What's your relationship to your race? What's your relationship to your age? What's your relationship to your gender, to your sexuality, to your socioeconomic status? and all the different layers of identity. So the social atom can be used as an assessment, an intervention, an evaluation tool. You can do it at different points in the treatment progress and compare them to see changes in one's social life. You can modify it into a role atom and draw all the different roles that you hold in your life rather than the different social relationships in your life. Social atom can be used as a warm-up to a psychodrama or to psychodramatic sculpting. So we could have someone or everyone in the group draw their social atoms and then get a protagonist from the group and then concretize their social atom by having them choose different people in the room to play the different roles and the different people that they drew on their social atom. And they can symbolically represent those relationships in the space of the group room or the stage, using body posture and closeness and distance, and even different nonverbal cues or even verbal messages to and from each of the roles and themselves. And this can be a entire group process on its own. Oftentimes it's done as a family of origin sculpting, and it can be a warm-up into a larger psychodrama. Now, the second important sociometric concept or model, we'll say, is called a sociogram. And so, whereas the social atom depicts the individual in their social environment, and it's person-centered, it's focused on an individual, the sociogram depicts the group as a whole sociodynamics, and it's focused and centered on the group as a whole, rather than an individual within that group. So Moreno created what he called sociometric tests, where he would ask members of a group or a community a sociometric question or prompt. And he would ask them to choose someone else in the group as the answer to that question. For example, who would you like to share a meal with at lunch in this group? Who would you like to go on vacation with? Who would you like to co-facilitate a group with? Who would you like to learn more about? Who here do you feel like has really helped you the most since you've been here? All these different questions could be sociometric prompts. And originally, Moreno would do these through pen to paper responses. He would ask everybody in the group to answer the same sociometric prompt. Sometimes he would complicate it and ask participants to create a list in order of preference and list multiple group members as in order of preference to the prompt. So who would be the top 3 people in the group that you would like to share a room with, or that you would like to be part of a group with? And he would take these responses from the sociometric test, and he would draw out complicated sociograms depicting the distribution of choices within the group based on that prompt. And so these sociograms provided a visualization of the different sociodynamics within the group, the distribution of social wealth in the group, and it would make it really clear who was the social star or the different social stars in the group based on that criteria, as well as who were the social isolates in the group based on that criteria. Moreno noticed that in every single sociogram and sociometric test that's ever been conducted, that there's always an unequal distribution of choices. That there's some people that get lots of choices, that get chosen a lot, and there's other people that don't get chosen as much or are entirely unchosen. And he described this social phenomenon as the sociodynamic effect. That this underlying phenomenon impacts all groupings of people, therapy groups, organizations, communities, and all of society, and it results in the unequal distribution of resources, of connection, of opportunities. Moreno described the sociodynamic effect as being underlying all problems in society. It fuels racism, it fuels poverty, it fuels discrimination, it fuels war and famine. That this sociodynamic effect shows up in all groups, and that part of our responsibility as group leaders and organizational leaders is to be aware of this sociodynamic effect and to actively work to reverse it within the group, redistribute the social wealth, the opportunities, the resources, and choices. And this sociodynamic effect underlies many, most, maybe all traumatic experiences through the unequal distribution of wealth or money or food or attention or love or opportunity, that neglect, abandonment, loss, violence, these are all fueled by the sociodynamic effect. Now, the positive side of this is that in these sociometric tests, Moreno also noticed a different concept, a different phenomenon that he called tele, T-E-L-E. And he uses this term to label this phenomenon that also emerged in all groups and all sociometric tests. And it resulted in the reciprocal and mutual choices between individuals in the group at a rate that was much higher than expected or even predicted based on chance. That as humans, we tend to gravitate towards each other and to mutually choose each other, that there's a reciprocity in our experience of each other that is far more unexpected than expected, and that it happens far more than what a computer would predict based on probability statistics. That in every sociometric test, if you were to predict what's the chance of two people choosing each other on this prompt, or what's the chance of somebody choosing three different people and those three different people also choosing them, and you do the probability statistics, and then you go and actually ask the group these sociometric prompts and compare how often mutual choices happen in real groups versus how often a computer would predict them to happen based on probability, that they're always going to happen more often in real groups, far more often. Moreno described this as a socio-gravitational force that brings us together more often than we would come together by chance. It's perhaps the mechanism by which synchronicity takes place. And tele shows up in psychodrama, not just in sociometry. It often shows up in the choices of roles, that we ask a protagonist to pick someone to play the role of your father. And they look around the group, and this one person just seems to catch their eye, and they say, I want you to play the role of my father. And they don't know anything about that person, but that person comes up, plays the role of their father, and they both have a really powerful experience in the roles. And then afterwards, in the sharing process, the role player shares with the protagonist and says how powerful playing the role of their father was. That they were struggling with their own relationship with their father or their own relationship with their child. And that it seemed a synchronicity that they got chosen to play that role because it was so meaningful for them in their own experience. We would call this tele. So tele is the opposite of transference. Tele is a two-way, accurate seeing, being, and feeling, experiencing of another person. Whereas transference is a one-way distortion of reality, a distortion of the relationship. So you could think of one of the purposes of all groups, organizations, leadership, and even one-to-one therapy as to help work through the different projections and transferences in the group in order to get to the telic connection that exists underneath of the transference. That all wholesome, healthy, and healing relationships are based on tele. So these sociograms, Moreno used them in large communities. He used them in the prisons. He first envisioned them in a refugee camp that he worked in. He later had the chance to use them in the military. He used them in educational settings and in businesses and in his own psychiatric hospital. And he was able to predict disconnections and losses in groups based on his sociometric tests and his sociograms. He could tell who the social isolate was in the group after some simple drawing some simple sociograms, and was able to predict who was most likely to leave an organization, leave a community, or leave a group based on who were the isolates in the group. So the sociograms became pretty popular in the sociology field, and they ended up becoming the foundation for social network theories, as well as for participatory action research. So Moreno is often credited as a forerunner of social network theory and participatory action research. One of Moreno's most popular quotes, and it's at the beginning of his book, Who Shall Survive, which is one of his most popular books. It was published in 1934, and it outlines his sociometric research. The quote is page 3. A truly therapeutic procedure cannot have less an objective than the whole of mankind. But no adequate therapy can be prescribed as long as mankind is not a unity in some fashion, and as long as its organization remains unknown. So Moreno really believed that one-to-one therapy was not enough, that we had to create healing in larger groups, communities, organizations, and we had to work towards societal change. He had a vision that he called sociometry, healing for society. And he really believed that we need to create therapeutic procedures that addressed societal problems and suffering and dysfunction within all of society. But that we couldn't create these types of therapies, group therapies, community therapies, and ways of creating change in community and society until we first understood the underlying structures within groups and societies, the underlying sociodynamics. And this is why he created his sociometric theory, sociometric research, and sociometric interventions. And we'll talk more about the interventions in chapter 4 of this book. So some questions to reflect on. If we were to generate a sociogram of your group, of your community, of your organization, or your team or department, who would be the people who are the social stars of that sociogram? And who would be the social isolates in that group? How can you, as a leader, a group leader, organizational leader, how can you contribute to reversing the sociodynamic effect within your groups, within your organizations, within your communities, within your team? So hopefully by now I've adequately covered how Moreno's theories and philosophies, as well as the theories and philosophies in group work, are not only can be used as trauma-focused treatments, but also are frameworks that are congruent with the trauma-informed care philosophy. And that these frameworks are applicable work with individuals, groups, communities, organizations, and all of society. That while group work approaches, theories and ideas, and psychodramatic theories and approaches were created long before trauma-informed principles were articulated by SAMHSA, that they really mirror each other, that these trauma-informed principles and trauma-informed care philosophy are both embodied in group work as an approach and as a theoretical system, and embodied in psychodramatic philosophies and psychodrama as an approach. So I hope you found this video useful. This is, again, providing an overview to the content in Chapter 2 in my new book, Trauma-Informed Principles in Group Therapy, Psychodrama, and Organizations. If you found this video useful, I encourage you to check out some of the other videos on the channel here. I'm going to create a video going through all the 12 different chapters in the book. You can get the book through the publisher, Routledge, Taylor and Francis, or on Amazon. If you find the book useful, it would be really helpful to me and to future readers of the book to write an honest Amazon review of the book. It only takes a couple minutes. Writing an honest Amazon review is by far the most helpful thing you could possibly do for an author or for a book to help new people find that book. So thanks for listening, and I hope you found this information useful in your work.